pneumatic system. By pressing on the button, the pneumatic system activates and the air column is forced over the cornea. At the point of flattening, then optoelectronic system, it directs collimated beam of light at the corneal vertex, and a receiver and a detector, they receive the beam. Then by it calculates by force applied over the cornea, and average time is 1 to 3 milliseconds, and one has to take at least 3 readings within 3 millimeter and has to take average of those readings. The disadvantages are that it usually measures higher than Goldman applanation tonometer, and so it is not a gold standard. All the tonometers are compared against the gold standard Goldman applanation tonometer. Then we have ocular response analyzer. It was developed by Research Instruments in 2004. It is also an applanation based device and air puff non-contact. But in this air puff, first applanates the cornea, then it keeps on, the intensity keeps on increasing until the cornea indents. Then the air puff intensity is decreased so that the cornea returns back first to applanation, then to normal shape. So there is applanation twice in this device. So it measures two applanation pressure, and it gives Goldman correlated IOP, which is mean of two applanation pressures. And it gives corneal biomechanical properties like corneal hysteresis, corneal resistance factor. Corneal hysteresis is the difference between two pressures, that is applanation 1 minus applanation 2, which shows the viscoelastic damping of properties of the cornea. It is corneal hysteresis. If the corneal hysteresis is low, IOP is usually measured fallaciously low. And it is an indirect measure that if corneal hysteresis is low, at lamina fibrosa there is some weakness, and it has been found that patients with low corneal hysteresis are more prone to have progressive glaucoma, and it is corneal hysteresis is found to be low in cases of open angle glaucoma. Then this corneal compensated IOP is given by ORA because it is a measurement which takes into account corneal hysteresis to determine an IOP value, which is not affected by corneal properties. Then there is corneal resistance factor, which is calculated by internal algorithm. And then another are pneumotonometer and tonopen, which are also applanation based, but they use dynamic applanation technique. Pneumotonometer is consists of 5 millimeter diameter tip, and the readings are displayed on a console, and the readings are usually overestimated from GAT by 2 to 4 millimeter. And this is tonopen, which uses 1.5 millimeter tip, and it is a pen shaped and gives readings over the display. And these tonometers are usually good when there is IOPs of normal range. Then there is rebound tonometer, which uses a small, very small 1.8 millimeter plastic ball on a wire, a stainless wire. The wire is pushed, when the button is pressed, the wire is pushed over the cornea. And it uses a principle that when the wire is pushed over the cornea, the speed of wire decreases, the deceleration occurs. So this probe contact time and acceleration are used to calculate intraocular pressure in this device. It is very useful in patients who are not cooperative for Goldman applanation tonometer or NCT because it's very light in touch and can be useful in children. And it's also useful in cases where the cornea is very bad, irregular, where other tonometers may not give good readings. Then we have latest is the dynamic contour tonometer, which was developed in 2005. It uses the principle of contour matching, and it displays there is piezoelectric sensor inside, and it detects dynamic IOP value. It gives IOP value as well as ocular pulse amplitude and a quality control. Quality, it gives value of 1 to 5. 1 means best quality and 5 means poor quality. The quality scores of less than equal to 3 are acceptable. It is said that in this IOP is not affected by central corneal thickness. It has been found in studies that DCT IOP is higher than manometric pressure, about it's 0.458 millimeter higher, whereas GAT IOP was found to be 4 millimeter lower. It has been found to be the most accurate of all, but still it's not widely used because of its cost. And in many cases where the cornea is not so good and it's irregular, it may not give the values, and because of poor quality, so it's still not used. So I'll also tell about the special consideration when we have to see the IOP value, because Goldman is also affected by corneal properties. So there are many conditions like thick or thin cornea, scarred cornea, irregular cornea, high astigmatism, refractive surgery cases, keratoplasty cases, and pediatric cases where we have to consider some other parameters. In thick or thin cornea, it has been found that thin cornea usually measures lower, whereas thick cornea measures higher. But still, we cannot give any correction factor because IOP is also affected by corneal biomechanical properties, and it has been found that DCT is less influenced by corneal thickness. Corneal scar. In corneal scar, the cornea becomes very rigid. At the site of scar, the cornea is very rigid, so it doesn't get applanated, and incorrect high IOP can be measured by Goldman applanation tonometer and other tonometers as well. In cases of corneal astigmatism, it has been found that if corneal astigmatism is more than 4 diopter, then the IOP measured is changed. Like there is change of about per diopter change 0.25 to 0.67 millimeter change. So if there is 4 diopter astigmatism, about 1 to 1.5 millimeter IOP is changed. So if there is a corneal astigmatism of more than 4 diopter, what one can do, one can either measure IOP in two axes, vertical and horizontal axis, and can take average IOP reading, or one can rotate the prism in the at the axis of flat meridian. One can place the red mark over the flat meridian so as to measure the IOP. And it has been found that tonopen XL, which measures over the area of 1.5 millimeter, can be more accurate compared to GAT in these cases if there is high astigmatism and irregular cornea. I have already told that DCT requires very good round tear film. So in many cases with significant astigmatism or sutures can affect IOP measurement in DCT and may not give value. And after refractive surgery, we all know that there is corneal ablation and biomechanical properties changes. So after LASIK for myopia, GAT usually underestimates IOP, and even NCT rebound tonometry are not reliable. It has been seen in studies that with ablation of 70 to 90 micron, there can be change of about 3 to 5 millimeter of mercury. We can use DCT in these cases or aura determine IOP corneal compensated. And even the studies have found that tonopen measurements on peripheral cornea are less altered and can be used as alternative to GAT. So what one can do, one can keep the record of preoperative IOP and can record postoperative IOP and can give the records to the patient. And preoperative disc photographs can also be additionally done before refractive surgery. After keratoplasty, we all know that corneal astigmatism, there is corneal astigmatism, biomechanical properties change, there is change in corneal thickness.
Dr. Deepika,
After DSEC, the properties do not. Hello, yes, ma'am.
Dr. Deepika, please wind
yes,
up. Yeah.
Yeah, 2 minutes.
Yeah.
And after DSEC, it has been found that usually GAT measurement is accurate, so we can use GAT in post-DSEC cases. But in post-keratoplasty, there is poor agreement between IOP, corneal compensated, and GAT. IOP corneal compensated has been found higher. In these cases, maybe DCT is more useful, but still we use Goldman applanation tonometer as a standard. IOP over contact lens, it has been found that over bandage contact lens or thin contact lens, we can use GAT, NCT as well. And so this was the special consideration where we should keep in mind some parameters. So, but we need to keep in mind that GAT tips also need calibration every monthly at least. So there is it is adjustable weight bar has to be attached, and the calibration has to be checked at 3 weights at 0, 2, and 6. And if we keep the weight at 0, then force dial should be kept at 0. And if we dial it backwards, then the feeler arm should come backwards. And if we dial the position forwards by 0.05 millimeter, then the feeler arm should fall forward. That means it's accurate and has to be checked at 3 positions. Disinfection of tips is also very important to prevent any infection. We all know that adenoviral conjunctivitis can be very common after using Goldman applanation tonometer. We do see cases when there is epidemic keratoconjunctivitis cases. We see so many cases. So we can use We can disinfect the tips by soaking for 5 to 15 minutes in dilute sodium hypochlorite. You can use 3% hydrogen peroxide, 70% isopropyl alcohol, or we can use wipe with alcohol. Many things have been seen that after wiping with alcohol, many of the viruses can be eliminated, or we can use 70% isopropyl alcohol. So points to ponder, we know IOP is the only modifiable risk factor for the management of glaucoma, and its measurement is very important. As of now, Goldman apprehension tonometer is the gold standard. A DCD is considered most accurate, but it's costly and yet not common in use. So what we can do in pathological corneas, we can use different tonometers, and we can examine the patient as holistically and evaluate the parameters like optic disc and visual field changes so as to diagnose a case and manage the case. Thank you so much.
Thank you, Dr. Deepika. There are no questions as of now, so I request the audience to drop in their queries in the Q&A section. I would like to ask Dr. Manish how important he thinks is the non-contact tonometer in the clinical practice. Dr. Manish, please.
Hello. Yes, sorry, can you please repeat the question?
Yeah, how important do you think is the non-contact tonometer in your clinical practice? How much weightage do you give to that?
Actually, in our hospital, we don't have a non-contact tonometer, so we don't use it. What we have been doing in glaucoma clinics, we always check the pressure ourselves, and we do have trained our optometrists. So whenever they do the workup, they check the intraocular pressure by applanation tonometry. In fact, applanation tonometry is much cheaper than a non-contact tonometer now with so many Indian companies coming. And we always regularly check their intraocular pressure to make sure there is not much of inter-observer variation. And I think that's working well with us.
Deepika,
Yes,
how frequently do you use non-contact tonometer in your clinical practice?
Ma'am, in routine OPD, we are using non-contact tonometer. For glaucoma patients, always Goldman apprehension tonometer has to be used.
Dr. Rajan, what's your take about it? What do you use in your practice?
Ma'am, I'm using NCT, non-contact tonometer, regularly in my clinical practice because first thing is I'm not very much accustomed with the applanation tonometer. That's a fact. And 99% of the ophthalmologists, they are not well versed with the applanation tonometer. That is a real fact. So we are using non-contact tonometer, and they're as good as for the screening purpose. I think it's one of the best tools and easier, and any staff can use. But applanation needs expertise for that.
Any comments from the panel?
I agree to Dr. Rajan that a lot of doctors are not comfortable, but no offense, but I think it's more of a mental block. See, you are doing a phaco under topical anesthesia. What is applanation tonometry for you? Nothing. So it's nothing, not a big deal. It's just like any other skill, you just need a bit of practice.
So I hope after this, I hope after this there is a little bit of practice change, and with this we move on to the next talk, and that's me. I am Parul Eshpujani, and I would be talking on one second, the optic nerve head evaluation.
Dr. Deepika ma'am, can you please unshare your screen?
Yeah, yes. I've stopped.
First of all, I would like to request to all speakers to please restrict to their timings. Please be in time, please. Thank you.
So good evening, everybody. I'll be just covering some ignored facts about an optic nerve head evaluation. I'm sure all of us as ophthalmologists have been looking at the optic discs, and we all have our own system of documenting optic disc. But as a glaucoma specialist, we need to remember that there is a lot of asymmetry even in the optic nerves. When we have asymmetry in nature, that translates even to the human body and in optic nerves as well. So, we have optic discs, optic discs themselves, and that variation of size is something that we often ignore. And what we have been traditionally using in our practice is the cup is to disc ratio. Now we simply write 0.4 cup, but that gives us no idea about the health of the neuroretinal rim or the thickness of the neuroretinal rim. So in the first three pictures, if we see, we have 0.4 cups, but the location and the shape of the cup makes an immense difference. So in the first and third, there is practically no neuroretinal rim in the area that I'm highlighting at the moment, while in the second one, the rim is healthy, it's equivalent all around. So that is in a healthy disc. But if I write 0.4 for this and it's assumed that it's normal, then I'm missing out on a major information of the neuroretinal rim. Similarly, a large cup does not mean that there is disease. So 0.8 cup with a large disc is practically physiological. So size of the cup and the disc and the health of the neuroretinal rim have to be kept in mind. So as I mentioned, that neuroretinal tissue or the neural tissue, it's the boss. So we have to see, is there enough neural tissue in the optic nerve head, and is this neural tissue distributed normally? So this is a normal distribution of the neural tissue, but here everything is fine here, but in the inferior nasal quadrant, there is no neural tissue. So the disc is unhealthy. So you look at the quantity of the neural tissue and its distribution. Sometimes you just have a cursory glance in an undilated disc and you will just pass it on and write it as a 0.4 disc. But we have missed a finding that the size of the disc in the right eye is larger than the disc in the left eye. So a smaller size disc with a small cup is quite suspicious for glaucoma. And we have to remember a larger size disc with a larger cup is more forgiving. Cup disc asymmetry is not always pathological, so therefore we need to look at the size of the disc. So as I showed in the previous image, the cup and the disc sizes themselves are asymmetrical. So if there is a little bit of disparity in the cup size, that really doesn't make a difference. But important is to recognize that finding and note it down, because it's very easy to start a patient on a timolol or a prostaglandin analog, but we don't remember that there is a gamut of adverse effects that comes with these drugs. And if these are given unnecessarily on just a suspicion, it doesn't really make sense. So there have been studies which have looked at disc size. Epidemiologically, yes, it has been found to be very, very relevant. And it said that the disc size is larger in glaucomatous. But when the studies have been done on OCT, it was not really, this was not really confirmed. And histologically also, this finding was not confirmed. So that means that even physiological discs can be large in size. So we have to remember that the large discs have large cups. I'm repeatedly reiterating the fact that most of the times when we get referrals for patients from the peripheral centers, these patients with a very large disc with 0.7 cup and good healthy neural tissue all around have been invariably started on timolol and sent. So that is something that you really need to remember. But we don't have time for all the mathematics to convert a cup disc ratio into a disc diameter. So we need to just remember that when we are looking at an optic disc on a slit lamp, we can just use the slit lamp reticule to measure the size of the disc, and then use the magnification factor for the lens, whether you're using a 90D or a 78D, to see what exactly is the size of your disc. Or you can even use a direct ophthalmoscope, wherein the 5-degree aperture of the DO corresponds to 1.7 millimeters square. So if your disc is falling within this, it's a small disc, and if the disc is falling outside this, it's almost like a normal to a large disc. So does cup size really matter? So here we have a very large disc. It's about 2.3 millimeters in size, and a cursory glance and you will say, oh, this is glaucomatous. But if you look at the distribution of the neural tissue, it is equivalent all around, and there is no area where it is missing. So isn't rule is well respected. So it just shows that high cup disc ratio may not be pathological. So this is this patient which has been followed up for several years, and even on consecutive follow-ups, there has been no change. So remember that large size does not mean that there is a disease. This is physiological cupping. You can call the patient 6 monthly to 1 yearly for follow-ups and see if there's any change happening. Now, if you don't click the photos using a fundus camera, you can use a smartphone to document the photographs, or you can just draw with your pen whatever you find it on the prescription of the patient, so that when you review them the next time, you have a reference point to fall back to. Whenever you're looking at a disc, this is a system which Professor S.S. Pandav has developed, and I've been mentored by him. And this is what I really find very practical in day-to-day clinical settings, that you need to mentally do disc dissection. When you're looking at the optic disc, always first evaluate a disc in a dilated scenario. Once you have dilated, do a mental dissection of the disc and see where is the neuroretinal rim. Now, if I see an undilated cursory glance, I can just say, oh, all is good. It's just 0.2 cup of cupping and, this is fine. But if I focus on just the neural tissue, I'll be able to pick up the atrophic change that is happening just beyond this. And I'll be able to mark the contour of the blood vessels. And remember, we don't have to fall for color of the cup. We have to follow the contour of the blood vessel that is there on the optic nerve head. So color cupping is not what we need to document. We need to document the contour cupping following the blood vessel. And once we do that, then the actual size of the cup comes. And since here the disc is slightly tilted, it makes it a little difficult. So try and pay some extra attention to the disc. And in a small disc, which is tilted with this much of cupping, it is a significant finding, and therefore glaucoma is a possibility. So you don't really have to commit in the very first go that, this patient has glaucoma or not. Keep a possibility or a likelihood so that you review the patient accordingly and come to a certain level of findings. So tilted discs are the one which in practice are very confusing. So here again, we have an obliquely tilted disc. All looks good. Even the central trunk of the vasculature is not visible. So all looks good nasally, superiorly, and partly inferiorly. It's only the temporal side. We have some amount of pallor and we have some amount of saucerization. But we also see that there's an immense amount of peripapillary atrophy or temporal crescent just adjacent to the temporal side. So when you see closely and you follow the blood vessels, you will see that the neural tissue is pale because of the oblique tint. And it's more of a refractive illusion that you're having. But since the blood vessels are good, the cupping is fine. The disc is slightly large because of the atrophic element, but the neural tissue is evenly distributed, respecting the Isn't rule, so glaucoma is unlikely. So this is how you can document, you can draw and mentally make a picture of what's happening onto the disc. Another example, so just see how much is the neural tissue. It is equally distributed all around. Color looks good, healthy enough. The fact that the cupping is large and you have laminar dot sign does not make it glaucomatous. Having said that, I don't mean that we don't do the adjunctive investigations. We obviously do that, but clinically also we make a picture that whether it is glaucomatous or not. Yet another image, similarly large disc with a large cup, and you make out the boundaries and all is well and equally distributed. Yet another disc, severely tessellated fundus, marked peripapillary atrophy. The pallor is quite marked. And if you see the distribution of the neural tissue, it's pretty scanty, almost absent on the supratemporal, temporal, supratemporal, and the infratemporal quadrants. So yeah, certainly it is glaucomatous. So this is the probability scale. You try to fit your patient into a normal, unlikely, possible, likely, or a certain category, and then corroborate your clinical findings with the other diagnostic findings that you have. The cup disc changes can occur more slowly in large than in small discs. So, the larger discs are more forgiving. Even if you miss your finding for once, nothing is going to happen. And cup disc ratios for large discs change by a smaller amount. They may represent just as much progression as greater amount of loss, but they change by a smaller amount. So keeping an eye and drawing changes in a larger disc makes much more sense so that you can follow back. So this change can be actually taken care by another parameter, which is called as rim disc ratio. So I will not go too much into details because I don't want you to develop another concept at this point of your practice. Even if you're using the cup disc ratio, I would just suggest that from now on, if you draw a diagram, you look at the amount of neural tissue, amount of neuroretinal rim, and the location of absence of this rim. I think that will give you a good enough idea. And if you start noting the size of the disc in relation to the size of the cup, that again will be quite helpful. So I owe my optic nerve head evaluation skills to my mentors, and this is the product of the training. This we have just come out with this book. If any of you is interested, I can share a PDF version through the AICE team for your benefit. But I would request all of you to start making a note of the neuroretinal rim and its health from now on and documenting in your cards. And I'm sure you'll have many of the patients whom we can save from unnecessary medications. So thank you very much. And yes, so we move on to any questions if we have.
I have one comment to make that for optic disc sizing, OCT is also a very good tool, because by looking over all OCTs mention the size of the optic disc, which clinically may not be easy to measure.
In some cases, sir, it is a good tool, but in cases where there is a tilt, and for every patient anyway, you need not get an OCT done in the very first glow when it can be done manually. But many cases, OCTs are not able to mark the boundaries well, especially when there is a peripapillary atrophy or there is a large crescent. There, the measurements given by OCTs can be fallacious. So that's my take on this topic. So we have a question from Dr. Lohan, Aparajita Lohan, and she asks me, how do we say that the disc is small or large on a fundus photo, not on a slit lamp? Well, on a fundus photo, you definitely cannot say, because you need to have a proper measurement. And the fundus photos can definitely be manipulated, zoomed in, zoomed out. So that's not a reliable way to say. You can always use a slit lamp or a direct ophthalmoscope. And with experience, I think you will just learn by yourself which would be a smaller or a larger disc. So any take of the panelists on this, which preferred measure do they use for a disc evaluation?
I think I'll agree to Dr. Parul that initially you can measure using a slit lamp. In fact, a lot of fundus camera have option of measuring the disc. So if you want, you can take a fundus photograph and use the measuring tool and actually measure the disc. But mostly on a slit lamp, you don't need to actually measure it. It's more like large, small, or moderate. A rough assessment is mostly enough to understand what you're looking at.
Dr. Talveer? Do you use OCT to document a disc finding?
Ma'am, no, ma'am. The clinical examination is the first and the foremost, and OCT I usually do to rule out glaucoma. Ruling in glaucoma is mostly clinical examination.
Right. So with this, we move on to our next topic, which is gonioscopy, and Dr. Talveer would be enlightening us about the clinical practice pearls of gonioscopy.
Is my screen visible, ma'am?
Not yet.
Just a minute. Is it visible now, ma'am?
Yeah, we can see your desktop, but not the presentation.
Just a minute. I'll stop it again and I'll share it once more. Is it visible?
It says that you've started screen sharing, but not as of now.
I don't know why this is causing a problem. Usually it's never a problem.
Can we go to the next talk and come back to you after the?
Yes, ma'am. Sure. Please.
Yes. So I would request Dr. Ravery to please step in till the time Dr. Talveer fixes this issue. Dr. Ravery, are you online?
Yeah, ma'am. Sure.
Yes,
sure,
please.
I will, ma'am.
So
I think Dr. Talveer's screen was visible.
Okay. Talveer, are you there? Can you do it? Yes. Yes. Right.
Shall I start, ma'am?
Absolutely.
Okay. So I'll be talking about the perimetry interpretation. And at the outset, I thanks GSI and SOFS for giving this opportunity. So in perimetry interpretation, we have got three goals that we want that whatever we are doing is reliable and free of artifacts so that a repeatable assessment of the visual fields can be done. To achieve this goal, initial fields are because tends to be abnormal due to several reasons from learning effect to poor patient's reliability. The first thing is to obtain a reliable and reproducible base field. It is most important step in the glaucoma management because it is the very field that would determine whether the patient's visual field is stable or deteriorating in future. Now, question is what constitutes a reliable baseline field? These two criteria may be used, which basically indicate that less than 2 decibel variability in the mean deviations can be taken as a reliable visual baseline visual field has been achieved. If you see in this screen, we have got three fields. From field 1 to 3, we see on repetitive testing, patients' parameters have changed and it is improved to the level where we can be rely as that baseline. There is no baseline, much defect is there, what we see in the initial two fields due to the poor reliability indices. Then next question comes that what test we should choose for the glaucoma assessment. Usually 24-2 size with a size 3 on white Sirsa standard threshold test is considered as the best choice in the patients of the glaucoma. Likelihood of such strategy is the missing the diagnosis of glaucoma in such strategy is very low and it's approximately 7%. So this can be used as a standard practice for the glaucoma evaluations. At the baseline, we can use the Sirsa standard, and for the follow-up test, we can use Sirsa fast. In cases of the advanced glaucomas, this 24-2 when is severely depressed, and such fields may not be sufficient for the follow-up changes in future. In such situations, we have two options that either we change the stimulus size to 5. The disadvantage with this is that when we change the stimulus size to 5, stat pack analysis would not be available for the statistical probability predictions. So we have to follow on our baseline fields for any changes in such cases. The second option is that we map more central field in such cases like 10-2 we can use, or macular threshold, depending upon the clinical scenario of the patient, that how much field is left over in such patients. Next in the visual fields comes is the what we say we have to ensure that field being interpreted is reliable. In Humphrey visual fields, there are 3 indices, and these most important of these 3 is most important is the false positive rate. It is the true indicator of unreliability of the test because it doesn't result from any eye pathology or the artifact, but solely on the patient's unprovoked responses. The false positive rate is displayed in the visual field printout with many ways, whether it's either it comes with a text message and a alert, or we can say in the sensitivity values that there is a supra threshold values are there, or white scotoma is there in the gray scale, or otherwise the alert text message also comes. The question is that how much we can accept, that depends upon the strategy. In the non-Sirsa test, we can go up to 33% acceptance, but for the Sirsa, it is up to 10%, and it is better that we keep it below 5 or up to 5. Such fields, if are very high false positive rate is there, then they should be repeated. Like in this field, we can say this is a field of a glaucoma suspect patients where we don't want to have any false positivity from field 1 to 3. On repetitive testing, we say the false positive rate has come down and field has improved drastically to set a baseline field for this patient. The second reliability index, most important, is the fixation loss, which measures the inability of the patient to maintain the fixation to the central fixation yellow light or the diamond. The upper limit for the CETA strategy is 15 to 20%, but this also depends upon the status of the other two reliability indicators. This fixation loss also comes with a flag message, or we can see it in the upshoots in the gaze trackers in the lower part of the field. This false fixation loss can be easily controlled, and machines provide different methods which are either technician based, or if the still patient is doing a lot of for fixation loss, then a good education before the test can help to improve the visual field outcome in such cases. As I said, the acceptance again depends upon that how much, what type of the strategy we are using. And in glaucoma suspect, definitely we don't want any fixation loss, because here we have to make a early decision for the diagnosis of glaucoma. Then the third indicator is the reliability is the false negative, which is a sign of losing attention or fatigability in the patient. It must be remembered that the advanced field loss may be associated with a higher false negative rates due to poor sensitivity of severely depressed points to restimulation. Similar to false positive indices, acceptable limits vary with the test strategy. And as I said, this mostly comes with the fatigue, and it can have a different morphological patterns, which can be seen either inconsistent depressed sensitivity on the overall field, or it can produce a clover leaf or the pseudocentral island pattern on the gray scales. Then once we have done this, we have checked our reliability indices, then we have to recognize the defect. And to this, we have got a StatPack analysis in which first we look for that threshold values. Usually we do not evaluate these values in the first go, but when we have to see the some particular point, then we come back and see this. So this is the basically this numbers in this deviation plot. These defects in the map in this threshold value is the patient's sensitivity. That's mean the what responses patient has got in that particular point, which is expressed in the decibels. So this raw data is next compared with the normative data of the machine with the age matched normative patients persons in the machine's data, and this displays as a total deviations. Then machine further adjusts these deviated values for causes which may produce generalized depression in sensitivity like cataract and the refractive errors, so that the focal changes becomes more obvious. And the most important numbers are tagged as a pattern deviations. So these deviations highlight abnormality of the visual field being tested. Once these numbers or in the deviation plots have been put, but this themselves doesn't make any significant information in a visual impressions. So machine next gives the statistical importance to each of these depressed point and displays them as a probability deviation maps, which not only tells likelihood of a point being abnormal depending upon its location on the deviation map using the probability symbols, which are based upon the p-values or the significance levels, but it also provides an estimate of the depth of defect, as well as they help in the making a recognizable morphological pattern when larger area has got involved. This depressions on the pattern deviation map, I've got a different values or different level of significance depending upon their location. As we can see here, that depression to the -5 decibel has a different probability symbols depending upon its location, whether it is more closer to the fixation or it is away from the fixations. Then once we get this depression pattern deviation maps, then we have to recognize what kind of the glucomatous defects is there. Before discussing these artifacts which poses the difficulty in recognizing the glucomatous defects, let's look out the various patterns of the defects which are common in this glaucoma. Here on your screen are the classical patterns which were defined for the kinetic perimetry, and they appear somewhat in this way on the static perimeter. Detection of the defects may not pose a difficult problems in the very obvious defects where the very clear-cut patterns are visible, as we'll see in the next 1 or 2 slides. But it challenges in the early defects of the glaucoma where they are very equivocal to make a diagnosis or to leave it like this. And there are several systems and scales are available to make them certain whether this is a actual defect or this is a variability. And obvious and advanced pattern of the defects will be picked by these scales, which we'll be discussing very in next few slides. Then because we have seen there are several types of the defects we see, the most likely defects which we see in the visual fields are in the arcuate scotoma and nasal steps or the paranasal defects, which constitute major type of the several manifestation of the initial defects. As I said, the changes in the arcuate area are most important. And this is the most important area just correlated with the visual field, that this area between the two arcuate vessels and just slightly going beyond that, starting from the blind spot, is the most important area for the glaucoma visual field defects. And then we see several of these shapes of the visual field defects from inferior nasal and superior nasal step, then paracentral defects, partial arcuate or a complete arcuate scotoma, or the temporal wedge defects as a manifestation of these glaucoma visual field defects. Then whenever we are seeing such defects, it is not essential that all the defects are exactly always belongs to the glaucoma. Then we have a differential diagnosis. Important in this is that we have to consider the artifact as well as the other optic neuropathies and the vascular disorders, as well as the congenital malformations of the disc should be kept in mind whenever we are making a diagnosis of the glaucoma. So this means that we have to take a holistic picture of the clinical examination in mind while making a diagnosis for these perimetric defects. One of the most common defects that complicates our diagnosis especially in the early patients or when the technicians has not used the lenses properly is the lens rim defect. Here I just give an example, like in the field 1 and 2, there are some rim defect is there, which was again repeating the fields and making the technician sensitive that there is a lens defect, rim defect is coming. So this was gone in the successive fields. One more common artifact which complicates the perimetric finding is the lid defect, which is sometimes because of the ptosis or the dermatochalasis is there, and taping the upper lid may can again help to remove such defects. Then based upon this information on the visual fields, then we have to make that what is abnormal. So what were the defect we are seeing, whether they are glaucomatous or not. Then we take the help of the 3 global indices, namely the mean deviations, pattern standard deviation, and the visual field index. Mean deviations gives primarily it gives that what is the average defect on the our total deviation was there, and based upon this we calculate the standard deviations, which basically suppresses the generalized depressions and make the focal defects more obvious. I will show in one slide that how this work and how this is affected by the generalization of the field and how it becomes more significant in the focal defect. Another one is the visual field index, which is a very good tool for the patients to make them educate that how much field is left with them. And one more good thing about the VFI is that it is not affected by the cataract and we can use as a simple guide for explaining the prognosis for the patients. Each of them has its usefulness depending upon the stage and severity of the perimetric loss, and most often they are used complementary to each other for early recognition of the change. Of this, PSD is important during most of the course of the glaucoma, but may not be helpful in the advanced cases of glaucoma. As here we can see here the mean deviation regarding the PSD. It is though it's a sensitive indicator, but you can see that it doesn't follow a linear relationship with the mean deviations. As we can see on this screen, that mean deviations and the PSD in from figure 1 to 4 are variable. The reason for is this, that in advanced glaucoma, when depression is generalized, the PSD falls back. This can be understood with this analogy. When the height variation in the small range, the standard deviation is small. When the variation increases, the standard deviation also increases. Though there is a little change in the mean deviation, but range has changed drastically. If it is further changes, then we see that again there is very less change in the mean deviation, but standard deviation has changed. But once the change becomes uniform, though now it's more severe, so range is again down, but mean deviation has changed, so the standard deviation has fallen back again. So that's mean whenever so PSD is higher in the localized or the irregular generalized defect, but lower in the generalized field defect, though they may be slightly deeper than the previous ones. So now the question comes, once we have an abnormal defect, that when to say it's a glaucoma. So we have used several scales and criteria. Most of the scales has been developed from the randomized clinical trials. The one which is used and very much popular is the HAP2 criteria, which includes abnormal glaucoma hemifield test and pattern standard deviations and the number of points depressed to a different probability levels. I just say a few words about the glaucoma sensitive hemifield test. It basically compares the data from the upper and the superior and the inferior hemifields, and compares that how much they differ from each other as well as from the normative data. It has been found to be a good sensitive and specific tool for the early diagnosis of the glaucoma. So we need not to do anything. Machines gives a message that it is whether falling outside the unit or borderline or a general depression or abnormal high sensitivity or a normal. So out of these 5 messages, 1 message will be there. So it is a very sensitive tool to say. But the 2 things we need to keep in mind, that it does not apply to the vertical hemianopia as well as for the temporal defects, the area which is not here in the colored in these points. So that area is also not included in the glaucoma hemifield test. So if we are seeing that any defect there, we have to ignore that slide. I'll just take 2 more minutes. And in this slide, you can see that this field fulfills the HAP2 criteria. But if we look carefully in the reliability indices, it has a very high false rate, which of subsequent field depressions are clear, and a normal field is obtained. So we need to be careful that even when criteria is fulfilled, it should be repeatable in at least 2 more field to say it is a glaucomatous defect. Then this criteria can also be used to consider it as a mild, moderate, and severe fields. Generally, we can use the mean deviation. If it is worse than -6 but better than -12, we say it's a mild. From -12 to 6 to -12, we say it's a moderate. And worse than 12 to 20, we say it's a severe. And beyond 20, we say it's a end-stage glaucoma. So we can use that HAP criteria to classify this. Another important thing is to be taken whenever you're examining the fields, we always keep the fields together so that you can detect the pattern, and especially very helpful to diagnosing that glaucomatous and the non-glaucomatous defects. Keep the right field on your right side and the left field on the left side, and that way you can interpret it. And this is to conclude that how we should approach when doing the perimetry, or we just, if you have first field is abnormal, and if abnormality is concomitant, then you have to accept this field and go for the glaucoma staging. If this is not acceptable, then repeat the field until you guess a field which is free of the learning effect and the artifacts, and the reliability indices are good. Then you can go for your glaucoma diagnosis and classify and stage the glaucoma based upon that. Thank you so much for your patience hearing.
Thank you, Dr. Devri, for the nice talk. But I would like to request all the speakers kindly restrict to the time. We are already, the session is running late. Only 2 talks are left in this session. Over to Dr. Parv.
Dr. Talveer, Dr. Avery, can you please stop sharing your screen?
Yeah, ma'am. 1 second.
We'll take the questions in the end in the interest of time. And over to Dr. Talveer now for enlightening us about gonioscopy.
Is my screen visible, ma'am?
Yes, yes, it is.
So I'll be talking about gonioscopy, mostly the practical aspects. We all know the principle of gonioscopy is to overcome the total internal reflection of light that happens on the cornea. And while we apply a gonioscope, the light can actually pass through the cornea and we are able to see the angle structures. The types of gonioscopy where we put a high power button like lens over the eye is the direct gonioscopy, but where we use a mirror based gonioscopy is the indirect gonioscopy. And I'll be talking mostly about indirect gonioscopy, which is mostly done in OPD. It's very important that before you apply the gonioscope, you should counsel the patient that we are going to apply a lens over your eye. The eye of the patient should be anesthetized. The patient should be made comfortable. According to the type of the lens that you're using, coupling fluid should be used. And while retracting the lower lid of the patient, the gonioscope should be applied into the eye and the patient should be asked to look straight. The most important thing is that it should be done in a dimly lit room or where the lights are slightly on the lower side. When you put the light of the slit lamp onto the eye, it should be a very thin and a 1 to 2 millimeter high beam, which should be only put at the angle so that the angle does not open up due to the light. So once you start doing your gonioscopy, you should always form a habit and you should do the gonioscopy according to a procedure, which I'm going to today explain. First of all, when you have put a thin light onto the angle, you should see what is the posterior most structure visible. So when you put a very thin beam over the angle, you see that there is a corneal wedge formation that happens inside the eye, which is the reflection of the outer and the inner cornea. At this corneal wedge actually lies your Schwalbe's line, and beyond this corneal wedge is your angle structures that are visible. If you are able to see the corneal wedge and beyond that you're able to see a single line, that means that some of the angle structures are actually visible, and that marks your Schwalbe's line. Sometimes the pigmentation is present over the Schwalbe's line, which you can confuse with trabecular meshwork. This will help you identify that structure. The second important marker for your angle structures is your scleral spur. So once you see the angle structures in a wide beam, you will see that there is a pigmented band-like structure, which is the trabecular meshwork, beyond which there is a stark white colored structure, which is the scleral spur. And beyond the scleral spur is a grayish ciliary body band, and over the ciliary body actually your iris is inserted. Sometimes the iris insertion might be high up, and we'll be talking about that later. So once you have widened the beam, you might be able to see the angle structures, for example, in these two upper pictures. But here you can see that you can only see the formation of the corneal wedge, but no single line beyond that, and angle structures are not visible. And you can see that the iris is curved upwards, which means it is a likely angle closure. And after you widen the light also, you are not able to see the angle structures. So this is a angle closure. So the upper two pictures are open angles where you are able to see the scleral spur and the trabecular meshwork, and these are the angle closure. And following that, what you see is what is the angle recess in degrees and what is the iris configuration. You have still not started doing manipulation or indentation gonioscopy. You have to note all these findings. So iris configuration could be convex, for example, in this picture, or it could be a straight iris configuration where the iris is flatly placed over the lens, or it could be curved backwards or a concave picture, which is usually seen in a pigmentary glaucoma. Here you can see that there is a band of pigment over the trabecular meshwork indicating, and a concave iris configuration indicating a pigmentary glaucoma. Following that, you do your dynamic gonioscopy, which might be indentation or manipulation gonioscopy, depending upon the type of lens that you're using. So if you're using a 2 mirror, you can ask the patient to look towards the mirror. So on manipulation gonioscopy, here in this picture, you're not able to see any angle structures. And once you ask the patient to look towards the mirror, you can see that this is the ciliary body band and the scleral spur and the trabecular meshwork, and there are no goniosynechiae. So this patient has iridotrabecular contact in primary gaze, but it fully opens up. So this is a primary angle closure suspect. Sometimes only on opening up the beam or making the beam wide, your pupil might constrict and the angle might open up. For example, in the picture on the right. And in people who have constant iridotrabecular contact, they start developing some sort of goniosynechiae. For example, here you can see that the angle opens up from this picture. The angle has opened up on manipulation only up to this area, but here the iris is still in contact with the trabecular meshwork. Here you are able to see goniosynechiae and blotchy pigments over the trabecular meshwork. Here also you're able to see small goniosynechiae. Here also the iris does not open up on manipulation. So these are the people who have started developing angle closure, and these are the people who are primary angle closure. And there, here gonioscopy, here YAG iridotomy must be done. And to differentiate between appositional or synechial angle closure, what you have to do is you have to do an indentation gonioscopy. Although your dynamic gonioscopy gives you an idea where or not you have to do YAG-PI, in very few cases you might have to do indentation gonioscopy to look for appositional versus synechial angle closure. So here you can see that while looking in a primary gaze, the iris is actually in touch with the trabecular meshwork, but when you indent and push the aqueous into the angle using your gonioscope, which is a 4-mirror gonioscope, you can see the trabecular meshwork and the scleral spur. Sometimes when there is complete synechial angle closure, there the angle does not open up on manipulation or on indentation. These are the people who usually have very high IOPs in the ranges of 40 to 50 and advanced angle closure glaucomas. So following that, sometimes now you have what you have seen is how to differentiate between open angle and closed angle. But sometimes when there is flat iris configuration, still the iris might be attached over the trabecular meshwork or over the even over the Schwalbe's line. So in the last picture, you're able to see that the iris is attached over the ciliary body band. In some normal eyes, the iris might be attached over the scleral spur or over the trabecular meshwork in juvenile open angle glaucomas. This picture A is of a congenital glaucoma where iris is actually attached almost near the Schwalbe's line. So this is anterior iris insertion in cases of juvenile open angle glaucomas and in case of congenital glaucoma. There might be pigmentation in the angle. You can grade the pigmentation. Grade 3 pigmentation is equal to the color of the iris. Grade 4 is more than the color of the iris. Grade 0 is no pigmentation in the over the trabecular meshwork. Grade 3 or grade 4 pigmentation might be present in pigmentary glaucomas, for example, pseudoexfoliation or pigment dispersion syndrome. Goniosynechiae we have already talked about. Goniosynechiae might be present in angle closure glaucomas or other glaucomas like uveitic glaucomas and or Axenfeld-Rieger syndrome like pictures or ice syndrome. But it's must that you differentiate iris processes from goniosynechiae. Goniosynechiae are usually tent-like, have a tent-like picture and they attach over the trabecular meshwork, but iris processes are very fine processes which actually they go along the angle and they go along the angle and usually do not go beyond the trabecular meshwork. So we have already talked about angle closure and blotchy pigments. This is uveitic glaucoma showing broad-based peripheral anterior synechiae. This is angle recession. This is Axenfeld-Rieger syndrome with posterior embryotoxon, which is an anteriorly placed band-like Schwalbe's line with multiple synechiae present to the Schwalbe's line. Here, sometimes we have seen that these people also somewhere they might go and they usually YAG-PI is done, but in such kind of people, YAG-PI does not really help. So YAG-PI should not be done in cases like Axenfeld-Rieger or ice syndrome. Then abnormal vasculature. Usually the normal vasculature of the eye, it is restricted only up to the iris. It does not cross the scleral spur, but abnormal vascularization crosses the scleral spur and arborizes over the trabecular meshwork. So it's important to differentiate between these two, and sometimes a reddish hue might come into the trabecular meshwork while doing gonioscopy. That is blood regurgitation into the Schlemm's canal from episcleral vessels. Angle recession it happens in traumatic glaucoma, which is widening of the ciliary body band. This is very important to recognize because more than 180-degree of angle recession might be associated with forming of secondary glaucoma due to trauma. And if there is a complete separation of the ciliary body from the sclera, that is cyclodialysis. Here, which can be seen as a whitening of white sclera being visible beyond the angle. So it's important to note all your findings and come to a conclusion according to which disease is actually present and what is the management of that particular disease. And gonioscopy must be done in all people who you are suspecting of glaucoma, and of people who have shallow anterior chambers to look for iridotrabecular contact. You should note your findings in a goniogram, and it is very important that you sterilize your gonioscopes. It can be done by soaking it in merthiolate solution or sodium hypochlorite, or by using hydrogen peroxide, or even isopropanol 70%. But sometimes with regular use of alcohol, the coating of the lenses, it usually starts diminishing. So that's very important. Thank you so much.
Thank you, Dr. Talveer. Wonderful presentation with wonderful images. And we'll take up the questions later. And now I invite Dr. Manish to please talk to us about the role of imaging in glaucoma diagnostics. Dr. Manish, please. Dr. Manish, are you there?
Yeah, I'm just trying to share it. Yeah. Is it visible?
Yes, it is.
First of all, I'd like to thank GSI and especially Dr. Parul for this honor and opportunity. So I'll be talking about imaging in glaucoma. So imaging glaucoma can be an anti-segment OCT or a UBM or a OCT. So we'll be focusing only on OCT in next 10 minutes of my presentation. 5 to 10 years back, we had multiple options for optic nerve imaging. For example, we had the HRT, GDX, and the OCT. But OCT is something which has survived the test of time. And because it has evolved over time, nowadays, even the HRT or GDX are hardly available. OCT, the reason it is survived because it is also used by other specialties. For example, the VR people, the retina people, they use a lot of OCT. So currently, spectral domain OCT is the most common imaging platform used in glaucoma. In OCT, the parameters we use for glaucoma is mainly the RNFL, and nowadays we are using gangliosine complex also. Optic nerve evaluation is less commonly done because there's lack of normative database and it is less useful. Among all the three, parapapillary RNFL evaluation is the most important parameter we see for glaucoma patients. So it's a useful tool, and I'll share a few examples where OCT can be useful. For example, a case of pre-perimetry glaucoma, you can see this patient, you can see there is a inferior wedge-shaped RNFL defect can be seen here, but the perimetry is normal. So it's a pre-perimetry glaucoma. In this type of patient, we can use a disc photograph for documentation, but for quantification, OCT is extremely useful. You can do the OCT. In OCT, you can see there is thinning of RNFL can be seen. And over serial OCT, you can use it to see the progression also as the disease is progressing. So this way, OCT is useful in pre-perimetric glaucoma for supporting your diagnosis and also for assessing the progression over time. But it is also important that you clinically correlate your OCT with your disc finding. For example, in this case, you can see there is an inferior thinning and the OCT is also showing inferior thinning. But if suppose you have done an OCT and OCT is showing superior thinning, then this is not clinical correlation. So whenever you're doing OCT, try to see whether the area of thinning is matching with your clinical finding or not, then only it makes sense. Also, it's very important in excluding glaucoma. I think the point where Dr. Tanvil was also mentioning that suppose this is a patient who already had a visual field which is normal, but the disc is looking very suspicious, superior rim is looking suspicious, patient has come for an opinion. These type of patient, OCT can be useful. When you've done OCT, you're seeing that the RNFL thickness is normal. It gives you an extra confidence to rule out glaucoma using the OCT. Coming to interpretation, there are various machines, so you should be aware of the machine which you are using. But in all these machines, before you go to these red and the yellow zone, which are very attractive and we generally tend to go there first, start with first seeing whether the name is correct or not, the signal strength is correct or not. Again, signal strength varies from machine to machine, so you need to check with your machine. Also check the RNFL thickness map, check for the RNFL deviation map, and then finally go to these RNFL quadrants and the clock hour, and then correlate with your disc finding. As I was mentioning, the signal strength is variable. So currently we have the Spectralis machine where the quality is more than 15 is acceptable. I'll just share a few examples to make it more practical. For example, this is a myopic patient where you can see there is a thinning superiorly, inferiorly in both the eyes. So definitely OCT is showing thinning. But if you see the disc looks fairly okay. The right eye, you can see there is mild inferior slope. Left eye looks like a temporal slope. There's no obvious neuroretinal thinning, which Dr. Parul was mentioning in her presentation. So again, very important, you have to clinically correlate your disc with the OCT or the field, because glaucoma is a disease of the optic nerve, and how well you can evaluate the optic nerve determines how well you can diagnose the glaucoma. In this case, there is a mismatch. There is no such superior thinning in the disc which is corresponding with the OCT. When we saw the patient again, you see there is a very poor signal strength in this patient. So in this case, when we repeated the OCT, the different machine with a better signal strength, we found the OCT was normal. So before you stamp that the patient is having glaucoma, properly analyze your OCT and your disc. Any patient with cataract, corneal opacity, vitritis, vitreous hemorrhage, you are bound to have a very poor signal strength, and these patients, your OCT evaluation of the RNFL can be fallacious. Another patient, a 50-year-old disc suspect. This is the patient I saw. I had gone to Jamshedpur in the pre-COVID era for a program, and that time I met one ophthalmologist who has purchased a new Sirsa machine, and he did a Sirsa in one of his relatives, and he showed me the report. And he just wanted my opinion. So I saw the disc. This looked to be suspicious, but when I saw the OCT, I couldn't correlate with it because there is such a gross thinning of RNFL. How can this patient with, say, a glaucoma suspect can have such gross thinning of RNFL? The signal strength was okay, but if you see the RNFL thickness map, it is totally blurry. The disc is not clear. It is definitely artifactual. There are motion artifacts. Then you see the TRS-NIT graph. The graph is actually touching the base. And if you see the actual thickness, it is actually 0, 21. Always remember, in an OCT, RNFL thickness cannot go below 50, never below 40. Whenever you are having this, because of the floor effect, even if there is complete thinning of RNFL, there is some neuroretinal tissues left. So it can't go below 50. So whenever you have this type of RNFL thickness of 0, 20, this means there is some error in management, error in measurement. So in this case, when we repeated the OCT was normal. So the point I like to highlight is that even in the high-end machine, for example, this Sirsa machine is a very high-end machine. You spend 40, 50 lakhs in the machine. So it will give you a false sense of confidence that now I can diagnose any glaucoma just based on OCT. That's not the case. These machines can also, you have to interpret the reports properly. So in this case, when you repeat it, you see the motion artifacts are gone, the segmentation is proper, and the RNFL thickness is normal. So don't be fooled by the price of the machine. Always evaluate the patient in totality. Again, segmentation error is very common. As high as 30 to 40% of your patient can have segmentation error because of poor quality of scan, because of poor signal strength. So segmentation is what? That machine is not able to delineate the layers of retina properly. Maybe because of the image is hazy, or there are some associated retinal problem. So if the machine is not able to delineate the RNFL properly, it will not be able to tell you the correct RNFL thickness. So suppose you have a patient with associated CME or an epiretinal membrane or a retinal scar, for example, a case like this, there is a CME. If you see the TSNIT graph, the machine is showing a very thick RNFL because machine is not able to understand where is the RNFL thickness. Because of CME, there is increased retinal thickness and machine is assuming that the patient is having a extremely thick RNFL. So these cases, I personally feel there is no point even doing our OCT RNFL evaluation. Macular scan again now is becoming very popular. We have been using it more frequently in our patient because in macula you see 50% of the retinal ganglion cells are associated in this just 2% of macular area, and the floor effect is seen much later in macular scan. So a lot of studies have shown that macular scan, ganglion cell complex scanning can be as good as RNFL scanning for your patient for glaucoma diagnosis. I'll just touch about the red and the green disease, which is very important from glaucoma point of view. So red disease basically is a condition where OCT mistakenly indicate that something is abnormal, although the patient is normal. For example, this patient with high myopia, you can see the scan is going through the peripapillary atrophy area. So because of this, machine is not able to segment this properly and is showing thinning of the RNFL, although this patient is having a normal disc. I'll show you one more example. This patient is an ophthalmologist. Anyone who has been practicing glaucoma, looking at the disc can see it's a very large disc. It's basically a physiological cupping in a large disc. This patient had a spectralis done. Now this is a 1 crore machine which we purchased 2-3 years back. When you do the spectra, it's showing thinning inferiorly in the right eye, superiorly inferior in the left eye. So even this high-end machine, they claim that you will have perfect centration and automatically centers the scanning around the optic disc. But in this case, you can see the centration was not correct. The left eye, you can very clearly see it's a decentered scan. So when I saw the report, I was myself surprised because clinically it's very clear that this is not a glaucoma patient. When we repeated the OCT with proper centration, which was done manually, we found that the OCT was normal. So as I was telling you, before you go to this red and green zone, see the signal strength, see the centration, see the TSNIT graph, then you go to your analysis and always correlate with your clinical finding. Coming to green disease is basically where the OCT shows that there is no sign of abnormality, but the eye is actually having an abnormality or a glaucoma. So for example, this is the case where you can see inferior, you can see an RNFL thinning and the disc hemorrhage is very clearly evident. So it's a clear-cut case of glaucoma, and even the red-free photograph you can see based on your clinical finding. But when you did the OCT is showing a normal. So again, this is a green disease. So basically what is happening, there is thinning of RNFL, but the RNFL thinning, in spite of the RNFL thinning, the database is showing that it is still within the normative database. So because of that, the machine is showing green. Machine can only show whether the RNFL thickness is normal, borderline, or abnormal. It is not based on that particular patient. It is just based on a normative database. So another patient, a glaucoma suspect, we're currently using this machine. So you can see we did a OCT, looks to pretty okay. So we thought it's everything is normal. That time we actually also had a demo TopCon machine. So because we had a demo machine, we did a TopCon also. And we were surprised that TopCon totally gave a different report. So machine to machine cannot be correlated. When you saw the TopCon report, there was inferior thinning and which are actually appearing to be matching with the clinical finding. So we went back to the spectralis report, and what we found that although in the clock hours, everything is green mostly and very little temporal thinning or borderline thinning. But if we see the TSNIT graph, definitely at one point it was dipping into the red area, which was matching with your TopCon finding. So again, don't just go by the clock hour. You have to see the TSNIT graph also, because some localized defects can be seen on the TSNIT graph, which can be missed on a clock hour, because clock hours, they give you averaging. I'll just share one more case. This is a young patient who was again already on anti-glaucoma medication with very advanced field loss. He had a OCT done also, which showing gross thinning everywhere. But when we saw the disc, it was advanced cupping in one eye, other eye 0.6 to 0.7 cupping. But it was more of a pallor rather than cupping. And actually, when we took the history, this was a case of methyl alcohol poisoning. The reason I share this case is that OCT again cannot differentiate a methyl alcohol poisoning or a traumatic optic neuropathy or ischemic optic neuropathy from glaucoma. OCT can tell you whether you have thinning or no thinning. Whether the thinning is because of methyl alcohol, that is something you have to decide based on your clinical evaluation. Before I end, I just touch about the progression. Again, for progression, accurate image registration is vital, because if the image registration is not correct, the data will not be correct. Most of these newer machines do have OCT progression analysis. So based on that, any 5 micron or more variation actually indicates progression in the spectral domain OCT. But even the aegis guideline, the most recent one, also has highlighted that most of these software, they don't account for the cataract or dry eye or aging changes or vitreous opacity. So this 5 micron change when you are having, you have to make sure that these artifacts are not there. But if you can take care of these artifacts, you are seeing changes in the same machine over time with proper image registration. Definitely OCT will show you progression almost 4 to 5 years ahead of the visual field. Before I conclude, OCT has limitation. First biggest limitation is the machine changes before the disc. 5 years back when we are using a status OCT, we had done OCT report. Now when the patient comes with that report is of no value because the machine is not available anymore. Now we are doing the test in a Sirsa machine or a spectral lace or some other spectral domain. So every machine, the data cannot be compared. So the machine has changed every 3 to 4 years, but the disc may not have changed. A 10-year-old disc photograph probably has a more value than a 5-year-old OCT report. Plus artifacts are very, very common. We don't see them actually, but if you start looking for them, almost 40% of the patient, you will find some artifacts. In my practice, I'll say I mainly use OCT for the pre-perimetric glaucoma and to exclude glaucoma rather to diagnose glaucoma. Again, cost is a very thing, because when you're seeing patients over time, you're doing also clinical evaluation also. Doing OCT repeatedly has a cost involved. So in not every patient it is possible, and artifacts I've already tell you, plus there is machine to machine variation also. So to conclude, I'll say OCT is a great tool to help assessing your RNFL and disc parameter, but whether the patient is having glaucoma or not, it is for us to decide and not the machine. Thank you so much.
Thank you, Dr. Manish. It was a very beautiful presentation with very helpful cases to corroborate what you have mentioned. We'll take up the questions in the end in the interest of time, and I would request Dr. Shibil Bhartiya now to talk to us about practical tips of medical management.
Thank you so much, GSI, and thank you so much, Sirsa Fatehabad Ophthalmic Society for this. For me, Sirsa is coming home. It's been home for me, even though I belong to Patna. It has been my spiritual home since I was very, very young. And so for me, this is back home to family. I'm going to talk about practical tips for medical management. And given that Manish Dalve, Dr. Revdi, and Deepika have already set the stage for how to diagnose glaucoma, it is extremely easy for me because half the battle is won when you diagnose, and the other half of the battle is won when you have started talking to your patient and encourage them to listen to you about treatment. The dramatic part of glaucoma that we consider, where we have to decide on treatment, that's really a no-brainer. We've really not been doing much over the last 1 century. That's 100 years, and prevalence and incidence of glaucoma-induced blindness have not changed. So perhaps we have to relook at our strategy. We seem to be focusing more on intraocular pressure and the decibels and microns that Dr. Praveen and Manish walked us through. And very often in clinical practice, those of us who are in private practice more than anybody else, also in the economics of glaucoma management. But what we do tend to forget is the quality of life costs of treatment. We forget how many patients drop out from our network. And we also forget to consider compliance and adherence. So what I'm going to try to do is cover the essentials pretty much. The essentials were all covered today. We didn't dwell on pachymetry today because I think Deepika, that was part of what you should have done today. But the essentials have all been covered of glaucoma diagnosis, and which constitutes, I think, almost 80% of glaucoma management. So it's very easy for me to take off from what people have already talked. And Deepika has done this beautifully. So how often do you measure your IOP? What constitutes your IOP baseline? And why diagonal variation is important, and why one-time IOP snapshot, whichever machine you use, is not critical enough for you to base your clinical judgment. Remember, there's a sleep-wake difference in your intraocular pressure, which is physiological. Remember, if your colleague has measured, Parul and I have worked together very, very often, but even our inter-observer agreement is not 2 millimeters of mercury. So that's something you have to remember, that when your colleague has measured your intraocular pressure, how are you measuring it? Remember, there is no way of knowing whether your patient was controlled at night or not. All of us have a physiological increase in eye pressure when we are sleeping, and this becomes more exaggerated in glaucoma patients. The beta blockers and alpha adrenergic drugs do not work at night. Prostaglandin analogs are the best at blunting nighttime peaks. I don't need to go into the evidence because this is a 10-minute conversation, but please accept this as gospel truth. There is really no challenging the fact for any of your patients that prostaglandin analogs are the first-line drug today for glaucoma management. You might consider, in the poorest of the poor, try not to do your OCTs. Try and stick to visual fields, because then the patient will have money left enough to afford a prostaglandin analog. Always, I would encourage people to stick to, whenever possible, innovator molecules, because if economics permit, otherwise a generic prostaglandin works just as well. As far as medication choices are concerned, remember, after a laser iridotomy, BACG is no different from POAG. And Parul and I worked together on this one. And remember Bali, Parul, so much fun this was. And I want you to remember this. BACG also has nighttime peaks. And it's critical. And while Deepika was talking, I made this slide quickly because Deepika had forgotten to mention how important pachymetry is when we are looking at glaucoma. Remember, unless you have a DCT that Deepika spoke of right at the end of her presentation, you cannot mention cornea-corrected IOP. And all the referrals that come in, so many of them have cornea-corrected IOPs because you are compensating for what you think is a thicker cornea. Remember, your patient can be anywhere on this bell curve. 95% of the patients will be there, but there will always be the statistical outlier where a thinner cornea will not be underestimating the IOP. So you cannot correct for the corneal thickness that 1 millimeter for every 10 micron thickness from 520 is not a valid correction factor. So please refrain from using it. But what you do know is that if you are dealing with somebody with a thicker cornea, your threshold for treatment can be lower because then, they are thicker corneas, so their chances of developing or progressing glaucoma become lower. That's all we know unless we have the DCT. And I think in this particular area where you and I practice, I don't think there is a DCT outside of the bigger institutes. I think AIMS has one and PGI has one. GMCH also doesn't have one, Parul, right? We definitely don't have access to DCTs. I am going to, again, borrow a slide from Talveer when Talveer spoke of dimly lit room, and she was not emphatic enough, which is why I put this in while Talveer was speaking. So this is a very interesting slide. Can you see the angle is open right now? Can you see the angle is closed right now? This is a UBM picture of the angle. And when I shine a torch in the patient's eye, do you see the angle is opening up? So Tanveer mentioned it in passing, but you must remember that gonioscopy is a dark room procedure. It is not to be done with normal ambient lights. You have the patient sit down on your slit lamp while you are looking at, putting in the gonioscope, have your lights on. But the minute you're going to start your gonioscopy, make sure somebody switches off the light in your room. That is critical to glaucoma diagnosis. And even if you don't look at the finer points of everything, but as long as you're doing a dark room gonioscopy, it's very difficult to miss angle closure. And that's something you need to remember. Now, what all of us need to remember in our clinical practice is that the experience that we have had in the past, our ability to interpret the evidence that is available, and our communication with the patient. These are so critical to clinical outcomes. And these have to be given as much weightage as patients' life expectancy, quality of life, their financial means of getting investigations and drugs, as well as access to your medical facilities. So what then is your target IOP? Your target IOP very clearly has two numbers. One is the IOP number range. Again, there's no 14, 15, 16, but there is a 14 to 18 perhaps, or a 8 to 12 perhaps. But you must remember that every time you add a drug, the risks of treatment should always be less than the benefits of treatment. Otherwise, you're doing something wrong. Remember, you must remember to look at the efficacy of your drug. You must look at how convenient it is for the patient to use. And you must also remember that it must be a safe alternative. So when we look at quality of life costs per millimeters of IOP, we always, and this is a patient from Agrasane Hospital. So Dr. Avery will perhaps recognize this gentleman. I sent him back to you. He had come from Jindal Hospital, and I sent him back to you for you to have a look, sir. So this gentleman is a very obvious bad case of glaucoma drugs being given to a patient. But you don't always find glaucoma reactions like that. The lady on the right is as affected by ocular surface disease. Can you see the pigmentation below her eyelids? That's the prostaglandin analog that was never wiped off in the dark circles. She's not going to progress to the brimonidine bad eye, but the prostaglandin bad eye is bad enough. Always remember that this is a long-term disease, and ocular toxicity and surface changes are going to surface over time. And the number and duration of treatment use will also impact the OSD symptoms. Always make a cursory tear film workup must be a part of each glaucoma medication. Also, please ask your patients what else they are using. Now even MBBS graduates being asked to do a 1 week posting in Ayush. Remember, there is a lot of pressure on patients from social media, friends and family, and also now that we are talking of all kinds of things which are not really evidence-based, everyone's drinking karhas of all kinds. Remember, 5 to 10% of your glaucoma patients also use complementary medication, which has nothing to do with what you've prescribed. 60% will not tell you. But what you can look at if you have to ask for something, these are written in the order of being important enough for have some anecdotal evidence at all. कोई अगर insist ही करे कि मुझे कुछ जड़ी बूटी भी खानी है, तो please उनसे कहिए गिंको खा लीजिए, बिलबेरी खा लीजिए, लेकिन दृष्टि मत डालिए आंखों में. The only drug which helps glaucoma, which it is sadly illegal, is weed, marijuana, and lots of famous people use marijuana. Whoopi Goldberg is one. Bono is another one. Both of them are very serious advocates of using marijuana for glaucoma, but we don't advocate it in the dosage that is required and the frequency it is required. It means you'll never be able to do anything else apart from smoke. I think this one gentleman has to be credited with more glaucoma progression than anybody else in the country. One is the Kapalbhati, which is actually a Valsalva maneuver against a closed epiglottis. You breathe out very, very heavily, and that causes a remarkable increase in your intraocular pressures. Drishti supposedly has garlic and ginger in it, but I am reasonably sure there's some element of steroid in it. I don't know how many of you have seen it, but I've seen a lot of patients of Drishti come back with all kinds of trouble, not just ocular surface troubles, but also increased IOPs. And lots of people under his influence have also decided to stop using their glaucoma medication. All of you must be familiar with this video. So because I had to add 2 slides for Talveer's and Deepika's presentations, I have cut out the video. Remember this woman who used the inhaler like a fancy perfume, came to Dr. House saying this inhaler is not working. Remember, you must make your patients put the eye drops in front of you, and you must always do it yourself. Show it to them. Demonstration is better than anything else. Most of your patients, and I became very cognizant of this, not because I did this paper, but because I got chikungunya and I had dry eyes simultaneously. And even to put a lubricating eye drop, my fingers just wouldn't be able to grip the bottle. So remember, your elderly patients who have arthritis are really going to struggle. And I don't know how many children will be around to put in the eye drops for your patients. And this is true for both multi and monodose vials. So be very, very careful. Also, this is my wonderful son when he was a baby, and when Parul and Aradhya, my boy, would gang up against me, and Parul would tell him when I'm entering the house. So the minute I was entering the house, I would see Aradhya sitting and studying. And when Parul didn't know I was coming in, I would have to go to the park and find him. So this Parul Aradhyanexus now is not so effective because now he's grown up and he doesn't care if I find him. So your patients are also like that. Remember, when I go to the dentist, I brush my teeth. So when your patient comes to you, they'll invariably use their glaucoma drops. And then you will be tempted into believing that the drug is not effective enough. So you have to ask for compliance. पिछले 1 महीने में आप कितनी बार अपनी दवा भूले? पूछना ही नहीं है कि आप दवा भूलते हैं या नहीं. So you cannot ask an open-ended question on this one. हाँ ना पूछिएगा तो वो ना ही जवाब देंगे. तो आराध्य से मैं जब पूछूंगी बेटा पढ़ा, तो वो कहेगा हाँ मैंने पढ़ा. उससे मैं अगर ये पूछूंगी कि बच्चे क्या क्या मिस किया पढ़ाई में आज, तो शायद फिर भी मुझे सच मिल जाए. और जो पुराने मरीज हैं आपके, वो मेरे टीनेजर बेटे की तरह हो जाते हैं बदतमीज. उनको पता होता है कि ग्लोकोमा में कुछ नजर तो आ नहीं रहा है, चेंज ना फायदा हो रहा है आपकी दवा का, ना उन्हें कोई नुकसान परसीवेबल नजर आ रहा है, unless of course it's end stage glaucoma. Then they tend to take glaucoma very lightly. Remember, because regardless of how much we warn them about it being sight threatening, they don't see damage to their vision for a very, very long time. So remember, about 60% of your patients will not use their medicines as prescribed, and you have to keep talking to your patients. And you must, at every opportunity, teach them how to use their eye drops. Thank you so much and for this opportunity. And after such a brilliant set of investigations, my job was so much easier. Remember to bring in your compassion to your science, because that's the only thing that can influence clinical outcomes. Thank you so much for listening in. I'll be happiest to take questions in the question answer box, and I will be writing to you because I think we've really overshot time on this presentation. Thank you once again.
Thank you, ma'am, for your nice presentation. Now I'll invite Dr. Talveer for her talk on role of lasers for glaucoma management. Dr. Talveer.
Is my screen visible, ma'am?
Yes, yes.
All right. So I'll be talking about role of lasers in glaucoma. This is a very vast topic to cover in 10 minutes. I'll be talking about the major lasers and the major parts about those lasers. So laser, as we know that once we use a lasing medium on any laser medium, so we can get a monochromatic directional beam of light which can be used on a tissue to have various effects. And if you look at the wavelengths of lasers, so it can be from ultraviolet to far infrared lasers, and according to the wavelength of the lasers, the tissue interactions, they vary. The ultraviolet lasers, they usually cause photoablation by breaking the chemical bonds between the tissues. Hence, they are used for incision making. The lasers like argon laser in the visible range or krypton laser, they usually cause photocoagulation where they denature the proteins, and we can use them to contract the tissues in the eye. The diode lasers in the range of 800 to 1000 nanometers, they cause photo disruption by forming ion plasma inside the tissue, and they cause shock waves and an explosive disruption of the tissue. And the carbon dioxide lasers on the far end of the spectrum, they cause photo vaporization and provide us a bloodless field for surgery. So the lasers that are used in angle closure glaucoma, usually for the relief of pupillary block, we use laser iridotomy. And for modification of the iris contour, we use laser iridoplasty. So laser iridotomy is actually creating a hole in the iris, like this, which can open up the angle by relieving the pupillary block. And a Q-switched ND-YAG laser of 1064 nanometer, which is photo disruptive, is usually used in doing laser iridotomy. The indications of PI are angle closure glaucoma or primary angle closure, where the people have started developing some goniosynechia in the angle after gonioscopy. But as I had told you that there will be some angle closure patients, people who have angle closure in primary gaze, but when you do manipulation gonioscopy, you will see that the angle opens up fully. It is a primary angle closure suspect. Not all the primary angle closure suspect patients need PI. Only those people who need repeated repeated dilatation of the eye, like diabetics, or people who are one-eyed, or people who are coming from very far off, who will never follow up, or people who have the other eye has developed angle closure glaucoma, they would usually need a PI in case of primary angle closure suspect. Otherwise, all primary or secondary angle closure would need a PI. Otherwise, aqueous misdirection or even sometimes pigmentary glaucomas, pigment dispersion syndrome, where there is a reverse pupillary block, PI is needed. Contraindications to PI are media opacities, very high risk patients like flat anterior chambers or uncooperative patients. When you select the site of the PI, usually the 11 to 1 o'clock is the selected site for PI because that is covered by the eyelid. Sometimes when the patient's eyelid, the aperture is very small, then you can still use a temporal site to do a PI. A contact lens, an Abraham lens or a Weiss lens is usually used to focus the light beam, focus the beam over the iris, which it also acts as a speculum and controls the eye movements. The technique of you doing a PI is that you pre-medicate with pilocarpine so that the pupil is well constricted and the iris is well stretched. And paracaine eye drops are put for anesthesia. If the intraocular pressure is high, it should be controlled before doing the PI. And the energy used is 4 to 6 millijoules. And number of shots should be actually restricted to less than 5 on the first setting. It is very important to explain to your patients because in India, we have brown irises and the irises are usually very thick. So multiple settings might be needed while doing a PI. This is a video of doing a PI where you first see and select the site of the PI. Here I'm trying to see where the iris is thin enough to do a PI. And in the superior part, you see multiple crypts over here. And then we put in the Abraham lens, and these are the two beams which are focused into one, and we focus over the iris, and in a single shot actually here the PI happens, and there is a gush of fluid which is coming out of the PI, relieving the pupillary block. So please do not do this. Sometimes I see PIs done very near to the pupil. It is important that PIs should be done 1 millimeter inside of the limbus over the peripheral iris. And also sometimes people are very over enthusiastic. If they cannot do a PI in one area, they try in another area, they try adjacent areas. They would give 50, 100 shots in one setting and still the PI will not happen. Please do not give more than 5 shots and explain to the patient that the patient should come next time when the tissue has contracted enough, and then even a single shot would actually make your PI patent. And to look for the patency of the PI, you can directly view in the slit lamp to look for your anterior capsule through the PI, or you can look for a retro a glow through the PI to look for the PI patency. Topical steroids are usually given for 5 to 7 days, and aqueous suppressants are given. Glaucoma medications are continued. If IOP is high, then acetazolamide cover can be given for 3 days. And repeat gonioscopy should always be done after PI. If suppose after your PI also the angle is closed, you should look for other mechanisms of angle closure like plateau iris, where your ciliary body is actually pushing up the iris, and you would need a laser iridoplasty apart from your PI. Also, sometimes your lens might be very thick with a very high lens vault, like in this picture, and on gonioscopy you can see a Mount Fuji sign, and or there might be a microspherophakia which might need a lens extraction later on. Complications of PI, there might be post-PI laser spikes, the IOP spikes, there might be hyphema. So it's important to take history of blood thinners before you do PI. All these old people will come to you with angle closure, and you have to do a PI. You should always take history of blood thinners. And apart from that, you might have corneal burns. And moving on to laser iridoplasty. Laser iridoplasty, as I've already talked, if it actually uses a coagulative laser. You apply 20 to 30 spots over 360 degree of the peripheral iris, 1 millimeter away from the root of the iris, to thin out the peripheral iris in case of plateau iris or angle closure glaucoma with thick irises. Now talking about lasers in open angle glaucoma. Laser is actually an additional treatment in the form of trabeculoplasty to open up the closed trabecular pores in open angle glaucoma. Earlier, argon laser trabeculoplasty was used which caused coagulative necrosis and shrinkage of the trabecular meshwork and opening up of the trabecular spaces. Argon or diode laser could be used. The settings are usually a smaller spot size of 50 micron was used over the pigmented part of the trabecular meshwork, and the endpoint was blanching or depigmentation. When you do laser, a gas bubble would appear at the focused site. Post-operative topical steroid is must for at least 4 to 7 days. And it was seen that good response is seen in chronic open angle glaucoma or pigmentary glaucomas, but poor response is seen in people who have uveitis or multiple surgeries or congenital glaucoma or angle recession glaucomas. The complications are immediate IOP rise, uveitis. You can have corneal abrasions or posterior synechia formation, failure in about 25% of people. Then we have selective laser trabeculoplasty. Selective laser trabeculoplasty actually uses very less energy as compared to ALT and a larger spot size, but it does not cause photocoagulative damage to the trabecular meshwork. It actually only shocks the trabecular meshwork and opens up the pores. A rich trabeculoplasty lens can be used. It causes less tissue reaction, and IOP spikes are less likely and uveitis is less likely. So when you compare the argon laser trabeculoplasty with SLT on electron microscopy, you can actually see craters formed on the trabecular meshwork when you have used ALT. As compared to SLT, a normal trabecular structure is used, while SLT uses only 1% of the energy of the argon laser trabeculoplasty. In long-term results, very few studies, I'm sorry, this is going on its own. So very few studies are actually long-term studies. One study of 2 years shows that around 6 millimeter mercury of decrease in pressure with both ALT and, and SLT, which reduces over a period of time. So now talking about refractory glaucomas and laser photocoagulation, which can be done by 3 methods. Either it can be transscleral, or it can be a non-contact transscleral, or it can be endoscopic. Please remind me of the time, ma'am, if I've overshot the time. Indications of cycloablation is refractory glaucomas, multiple failed surgeries, or painfully blind eyes. A standard protocol is 1500 milliwatt energy is used for 2 seconds per spot, and 6 to 7 applications per quadrant is given like this. A G probe is used, which actually places the fiber optic probe for giving the energy 1 to 1.2 millimeter behind the limbus to apply the energy directly over the ciliary body. Post-operatively, steroids and cycloplegics have to be given, and it is very painful. Even in children, when you're doing DLCP on table, the block should be given to children. And IOP reduction is usually seen in 1 month. Over time, tapering of drugs should be done. Complication is usually surface conjunctival burns, and ciliary body hemorrhage or intraocular inflammation can happen. And in endoscopic cyclophotocoagulation, the photocoagulation is done from the inside, from the limbal root or the pars plana root. And we also have nowadays micropulse diode laser, which can be, which actually has a very small duty cycle, due to which it gives very less inflammation. And even in seeing eyes, you can do a diode laser, where multiple surgeries have been done already. So it decreases the aqueous humor production by selective destruction.
Can we skip the mechanism, because we are just 10 minutes short and we still have 2 talks remaining?
Yes, ma'am. This is almost my second last slide.
Right.
So in post-operative treatment, we can use laser for suturolysis. This is a blue menthol lens, which you can see. It can be applied over the bleb to look for the sutures over the sclera underlying the conjunctiva. And laser can be used to actually break these sutures if there is increased intraocular pressure, so that we can release the scleral flap. And if there is a blocked ostium due to the iris, then ND-AG laser can be used to actually unblock the ostium. So thank you so much. This is all about my talk. It's actually a very big topic, but the important things to remember is especially YAG-PI, because YAG-PI is very commonly done. That is why I covered it a bit extensively, and these points should be remembered. Thank you so much.
Thank you, Dr. Talveer, for your elaborate presentation. And I would call again Dr. Shibal for her presentation on who is the right patient for glaucoma surgery.
Once again, thank you so much for having me here. And Parul, congratulations for having designed a really cool program. It means that everything follows each other in logical progression. And it is so easy to follow Talveer, because she just sets the stage for everything brilliantly. Just so brilliantly done, Talveer, just so much more sensible to concentrate on what we actually do every day in our clinic. And those are very real pictures that she showed, and those are very real mistakes that I have made as a resident, and I have learned the hard way. I wish Talveer was a teacher when I was a resident. So really, really happy to see her grow up into this brilliant teacher. Really, really, really proud. I take great pride in this girl being a part of my life. So who then is the right person for glaucoma therapy? The glaucoma care pathway has been always, jab sab kuch khatam ho jaye, you reach the end of the road, that's when you consider surgery. That's because there were significant post-operative complications that you have to keep in mind. You have to also remember prolonged recovery times. And in case you're in private practice like me, you also have to remember patient kab aake tumhare upar case kar dega. But remember, the poor prognosis with glaucoma surgery is also because we do it very late. And because the patient has not been compliant with your medical therapy for the longest time. And because of prolonged use of both drug and BAK, invariably patients have ocular surface disorders. So even though the traditional glaucoma care pathway is medication, laser, and surgery, primary medication after that, and laser if required as a supplement is equally intelligent a choice, as is laser first. Talveer didn't speak of SLT much because I know she realized that not many of us have access to SLT. I think the closest SLT for me is in Delhi with AIMS, and for all of you in Punjab would be Chandigarh with Parul and the PGI, right? So, but laser for glaucoma is an important thing to remember. It's also important to remember that you have to look at lots of parameters in the patient, which include not just the relevant ocular, but also the systemic biological factors, mechanism of glaucoma, how high the IOP is, how quickly is it progressing, what is the life expectancy of the patient and general health of the patient. And I referred, I think Praveen Munga is not here right now, right? I referred a patient back to Praveen, who he had sent across, I think, to me. And she was 76 years old looking for a trabeculectomy. And Praveen was very correct when he said that, I don't think that's the smartest thing to do. It's all right for you to just take drugs and see where it goes. Psychological considerations. If you have somebody who's super scared, if a patient walks into my OPD saying, "Meri aankh bacha lijiye, Dr. Sahab," that's just the patient I'm not going to touch surgically right then. Unless the patient has realistic expectations, it's not logical to take that patient up for surgery. Remember, surgery comes with a serious quality of life cost, many follow-ups, many repeat procedures, socioeconomic factors also. Very important to remember, especially for lots of patients when we say the patient can't afford medication for life. Do you think it's more sensible to just pick up a trabeculectomy and do that for that particular patient? Primary trabeculectomy and primary tubes also have been given enough validation in Africa and also in our country now But remember, the average lifespan of any, even a decent trab, would not extend beyond 10 years. A reasonable trab is 5 years. So you have to keep all of that in mind. And of course, given that you are living in India, spiritual decisions also have to be brought into the whole spectrum. So the primary decision-making algorithm then is whether you will do the surgery or not. The secondary decision is going to be how are you going to sequence it? Are you going to give the patient a trial of medication? Are you going to give the patient laser first? When will you do the surgery? Where will you position it in your care pathway? And also, which surgery are you going to perform? The which surgery gets limited to trabeculectomy in our case, because none of us have access to MIGS. None of us are trained in NPDS apart from a very few. And seriously, most of us are not very comfortable putting in tubes either. So which surgery is not really much of a question, but it does remain when you do the surgery. Remember, patients with advanced damage or that is threatening central fixation require lower IOPs. So you must consider a surgery in these patients, but also you must remember that those with split fixations may be at higher risk of snuff out. More than snuff out, I think vision loss following glaucoma surgery comes from hypotony. So be very, very conscious in these patients. There's also spikes in intraocular pressure if you've left viscoelastic behind or if your sutures are too tight. Wipeout per se causing decreased vision happens in less than 1% of surgeries, and many of these get reversed if you give them a high dose of systemic steroids. So even though we worry more and more about wipeout and snuff out, remember a bigger concern in advanced glaucomas also should be hypotony maculopathy. Fellow eye, if the fellow eye is at vision loss from glaucoma, you should lower the threshold for your IOP management. Consider a safer surgery. I do use NPDS in some of my patients, but I've stopped that almost for everyone because we don't have the appropriate star implant here. And to do an NPDS without having access to an implant is almost criminal, I think, because most of them scar down. And in case of post-trab hypotony or extensive scarring, you might want to consider an alternative like putting a tube first, if you are trained in doing a tube. AGV is also now coming with a valve-like implant without a valve, just so you know, because apparently they are more effective than valved implants in glaucoma surgery. None of us, however, who've trained in the country or even in Europe have been trained in the use of the bar weld. So it's a good idea to practice on the Adi. So when you do have a better implant, you'll be trained in it. Life expectancy, remember, most surgeries, like I mentioned, will fail within 5 to 10 years. And for relatively young patients, so then is it important to consider MIGS? I have a typo on my slide. I am so ashamed of myself because I was looking at Manisha's slide and I was typing a spelling error. Surgery mein why hota hai, mujhe pata hai. The most efficacious procedure is always not the most safe procedure. MIGS, even though they are safer, are usually minimally effective. So do you want to give somebody young a surgical procedure which is not very effective, even though it does spare the conjunctiva? These are real considerations. With JOAG, you really don't have a hope. You just have to do the best you can. And I do this in my practice, in spite of having been a trained glaucoma surgeon, and I do only glaucoma in my practice. I have now understood that congenital glaucomas are best managed at higher centers. किसी के भी पैर पकड़ लो, मैं तो पहले डॉक्टर रमनजीत के और डॉक्टर तनुज दादा के पकड़ती थी. अब डॉक्टर रमनजीत एम्स से चली गई है, मैं तो सर को फोन कर रही होती हूँ. Congenital glaucomas, unless you have access to almost everything in the world, are best managed at the higher centers. I know it's a tremendous pressure on the bigger tertiary care centers, and Parul is going to hate me, but we should really refer our congenital glaucomas. JOAG is also your threshold for referral should be a little lower than for your other patients. For the elderly patients, you can choose between trabeculectomy and the tube. I am more comfortable putting in a tube. I know Parul is much more comfortable doing a trab. So our practice therefore diverges from there. Other coexistent factors, of course, include conjunctival health, the lens status, whether the patient is systemically fit, and whether there are certain diseases that will compromise the health of your filtering bleb. Ocular surface disease is increasingly important because of bleb-related complications. We do not pay much attention to bleb dysesthesia, but if you've done a good trab and there's an overhanging bleb and a patient is perpetually complaining about being uncomfortable, you'll remember how that feels. Glebs with tubes are much more posterior. And being a tube advocate, I always find that easier. In which, yeah, tubes come at a much higher cost. Remember, 5-fluoro is less toxic, but MMC is more potent. Patient expectations is something that you have to learn to manage. Remember, glaucoma surgery is not LASIK. And thanks to our cataract and refractive surgery colleagues, it's a nightmare practicing surgical glaucoma now. Everyone expects the surgery to be a cure and to give you 6/6 vision. So you have to be very, very emphatic when you take your consents about this not causing any increase in vision at all. In fact, you might have a vision drop of 1 to 2 lines following surgery, which may persist for as long as 6 months. Lots of information comes from the internet. Everyone will come to you and say, laser kar dijiye aankh mein meri. And then you have to be in a position to explain to your patient that that's really not going to happen. And you must also educate your patients at initial evaluation and not just when you are going to do the surgery. Basic understanding of the disease will set the framework for patients' expectations, showing them their visual fields and explaining to them how little they have left can be very critical. And you have to emphasize that this is not going to improve their vision in any way at all. Remember, our first principle is to do no harm. And we must, at each time point, measure the risks versus the benefits of taking the patient under the knife. If an optimal medical therapy, I'm not saying maximal medical therapy, I'm bringing in quality of life here also. If optimal medical therapy together with laser fails to sufficiently lower IOP, consider surgery. If the patient does not have access or cannot comply with medical therapy, consider IOP. Similarly, I send my patients out for SLT because I don't have a machine. But please tell the patient that that laser is again not LASIK. It hasn't cured that disease. It is a very short-term temporizing measure. This one slide I thought would be an interesting add-on. In coexistent cataract, please consider sequential surgery. It's always more sensible to do 2 surgeries rather than 1. Choose your bigger evil that you need to address first. Phacotrabeculectomy is to be used in certain cases only. I'm going to list them here, but you know when to do a combined surgery. More or less, especially when both are equally important and when you cannot do 2 surgeries in 2 sittings. Remember, this is the era of precision medicine and you have to customize. No one size fits everyone. And there's always an N of 1 trial. Each one patient of yours is going to react differently to absolutely everything. Put your patient first when you take a decision. Remember to refer your patients. Please find, there is no harm in referring a patient. And to those who receive referred patients, please send them back to the referring doctor because that's how you build an active referral base. If you send a patient to any one of us and we operate on your patient, we promise to send you back the patient. We do not hope to keep your patient because none of our practices need that kind of load. Please do it within yourselves because unless you build up a strong network of colleagues who specialize in certain things, you're not going to be able to take care of glaucoma, which is severe. I don't do it myself, and I'm reiterating that I refer all my congenital glaucomas. And that is what is critical to remember. And this is a very, very special slide because it acknowledges a very special person in my life. Most of these slides are courtesy Paralich Pujani. She could very well have been speaking this. I wasn't very well. I have been in bed. In fact, I'm taking these classes also from bed because of a very, very bad back. I had too many commitments and I was like, Parul, kuch kar, mere paas to gat ki slide nahi hai. So she said, main bhej deti hu. Maine kaha, tu bol bhi de, mujhse bulwa bhi kyun rahi hai? So all questions about who to do surgery on should be directed to Dr. Ichpajani, lifesaver and best friend. Thank you so much for listening in and thank you so much for accommodating all of my unreasonable requests. I must be the most pampered brat in the world.
Thank you, ma'am, for sharing your practical points. Now, I would invite Dr. Manish Singh for his talk on optimizing TRAB outcomes.
Thank you so much. It was really nice listening to Dr. Shibal, and she shared a lot of practical points deciding where we should be operating and where not operating and when to refer. I'll be just sharing few practical tips about how to enhance the success of trabeculectomy. Are my slides visible? Hello?
Yes.
Okay, thank you. So this is what we aim for, nice diffuse bleb, slightly avascular with IOP in early teens or maybe even single digit. But the reality of trab is far from ideal, and blebs can come in all forms and shapes. So it's the unpredictability of trab which actually makes it a very exciting surgery. So even if you are the best glaucoma surgeon in the world, it's very difficult to predict that on day one the pressure will be 4, 14 or 40. So it is so difficult to predict. But we should follow certain guidelines to enhance the overall success of our surgery. Choosing the right patient is also very important, especially if you're starting trabs in your practice. I'll say you choose patients who have virgin conjunctiva, untouched conjunctiva. Avoid failed trabs or difficult cases like neovascular glaucoma or a post-VR surgery or a uveitic glaucoma, because they do have a higher risk of failure, and it will be bad to start with those difficult cases. With the use of so many anti-glaucoma medication, overall the indication for glaucoma surgery has decreased in last 2 decades, especially after the prostaglandin came into the market. But then now the surgeries have become more demanding, because now most of the patients whom we are operating are actually more advanced glaucoma and a lot of young patients. So there we need even lower target intraocular pressure. So in a way, the surgery has become more demanding than what it was. Preoperative preparation is very important. For example, I use routinely topical steroids for a week in all my patients, because all these patients are on 3 or 4 medication. They have congested and inflamed conjunctiva. A short course of steroid definitely makes the eye better and enhances the success of surgery. I do stop anticoagulants for all my patients with consultation with the cardiologist in case the patient is using a stent or patient is having a pacemaker. We continue all anti-glaucoma medication, and I'm using routinely IV mannitol pre-op unless it is contraindicated because of certain systemic factors. The counseling part which Dr. Shibal was highlighting is very, very important. In current practice, we have to understand that glaucoma surgery is a surgery where the vision can go down but can never increase. So this is one surgery where pre-op counseling is extremely crucial. There are innumerable complications that can happen in trabeculectomy. You should always have a proper consent form in the patient language, share with the patient, let them read it, let them ask the questions pre-op, because in case they end up in any complication and they lose the vision, they should be aware that they have been informed about all these possibilities. Coming to anesthesia, topical anesthesia is best if you are comfortable. Personally, I like a bit of echinacea, so for me peribulbar is a better option. Avoid retrobulbar injection because you're going very close to optic nerve, and these are already compromised nerves, so this retrobulbar injection can further compromise your optic nerve. Whether you should use a superior suture or a corneal traction, personally I believe corneal traction is the better option because you have no chances of a hematoma formation or a bleeding from the superior suture. And superior suture, if there is a bleeding, blood we know is a pro-fibrotic, so it can increase your risk of failure of trabeculectomy. Positioning of filtering ila is again very important. Whenever you're doing trap, try to do it either supranasally or supratemporally. Don't dissect a large area of conjunctiva, because this is a patient which I'm showing. This is actually the third trap we are doing this patient. So remember, even if you are the best surgeon, the traps will fail. A lot of traps will fail over time. So always keep some conjunctiva healthy for future surgeries. Don't damage a large area of conjunctiva that you can't do surgeries again, or you can't do a repeat trap in future. Whether we should do a limbal base or a fornix base, worldwide, I think most people have shifted to fornix base because it gives you a much better exposure. You get a more diffuse bleb. But yes, there is a risk of bleb leak, which is more compared to a limbal base trap. In limbal base trap, because you're suturing conjunctiva to conjunctiva, there's less chances of leakage. But this suture line between conjunctiva to conjunctiva acts as a ring of steel, and it prevents the posterior flow of aqueous. So you get more localized blebs. You have more tenacious formation. You have higher risk of blebitis. I use mitomycin routinely all my patients. Whenever you're using mitomycin, try to avoid the edges of conjunctiva because that will lead to increased leakage. Dosing of mitomycin is something you can plan pre-op. whenever you're planning your surgery. So suppose I'm dealing with a case of neovascular glaucoma, I'll use a high dose of mitomycin. I'm doing a TRAB in a primary opening of glaucoma, I'll use a lower concentration of mitomycin. So depending on the etiology, depending on the conjunctival condition, depending on the age of the patient, tenon thickness, you can determine pre-op that what is the dose of mitomycin you want to use. Generally 0.2 to 0.4 for 1 to 3 minutes is something which has been practiced. Also conjunctival mobility. For example, this patient already had a VR surgery done. You can see an inferior PI here. You can see a vitrectomy port here. So what you can do, you can inject a bit of lignocaine or a BSS and see which area the mobility is good. And then you can plan that this is a place where I want to do the surgery. So in patients with multiple surgery, this can be planned. This is a patient who was actually referred to us for a bleb needling. And when we took up the patient in OT, we found that it looked a bit abnormally elevated. So we explored this and we found that there was actually a retained. So whenever you're using sponge in mitomycin, try to have larger size sponge. Don't have half cut sponges, and always count your sponge yourself. Don't be dependent on your sister or someone else to count the number of sponges. Whether we should use a triangular or a square flap, I think theoretically both of them give you equal result. I've been using triangular flap for almost 5 to 6 years. Then I shifted to square flap, and I tell you the reason for it. Personally, in my hand, I find the square flaps, they do better, or rectangle flap to do better. This is the case. You can see this is a stoma and this is a triangular flap. And when you put a central suture, and there is a flow of aqueous, generally the aqueous tend to flow more towards the side because centrally you have prevented the flow. So we get more of a diffuse bleb which are more toward the side. On the other hand, when you're switching to something like a rectangular flap with the base which is bigger, say 4 to 5 millimeter, and vertically it is 2 to 2.5 millimeter, and you're putting the two sutures on the side, you are making the flow more posterior. So when I switched to this type of flap, I started getting more posterior and more diffuse bleb. Plus, since the flow is directly posterior, the incidence of limbal leak in my practice actually went down. So this is something which I have been doing. Just a small video of the technique which currently I'm practicing in my hospital. A rectangular flap, base around 5 millimeter, vertically 2 to 2.5 millimeter. I always use a pre-placed suture. You put the suture. AC entry can be done with a keratome or with a side port. And then you've done a PI and you close the sutures. Now, paracentesis is very, very important because post-operatively, if there is a shallow chamber or intraoperatively, if you want to see the flow, you can inject the fluid through the paracentesis and you can see the flow of the aqueous. I always use pre-placed suture. For example, in this case, you can see this is a post-VR surgery TRAB we are doing. You can see inferior PI. The pre-op pressure was 40. We gave them mannitol. Pressure came down to 30. But even then, when you are opening the eye, the pressure suddenly drops from 30 to almost zero. So at that time, when the eye is open, this is a time when you have these complications like suprachoroidal or expansion of the blood vessels. So in this case, if you have a pre-placed suture, you can immediately suture it and you can save a lot of valuable time at that critical juncture. Releasable suture, you should use, like whenever I was using triangular flap, I used to put a central interrupted suture, and then whatever extra suture I'm putting, I'll use a releasable suture. Releasable sutures are extremely useful because you can go for a watertight closure on table and later on you can release it. So I just repeat this video once again. So you can see I'm entering from the cornea, then we are coming to the scleral flap, and then from the scleral flap to the scleral bed. And then you take 3 or 4 loops. This is a 10-0 nylon suture, 3 or 4 loop, and then you can suture in the central port. There are various techniques of using releasable suture. This is the current technique which we are following. And post-operative, you can just conveniently pull the suture end. This is the suture end, and you can just pull it over a slit lamp. You can see the suture coming out, and a little bit of massage can be given, and then you can see the bleb nicely forms. You can see the nicely formed bleb. Mostly we don't do partial tenotomy nowadays because tenotomy leads to more tenon cyst formation. But in case you have a very thick tenon and you think that you may require a suture lysis later on, so when you are closing, for example, in a limbal based trap or a fornix based trap, when you're closing the conjunctiva, you can put the conjunctiva over the scleral flap, and if you can see the sutures, then it's good. If you can't see the suture, maybe you can consider going for a partial telectomy. In suturing, I'll just highlight one point. Since we're using a fornix based flap, suturing is extremely crucial because you need to have a watertight closure to reduce your chances of limbal leakage. So currently, I'm using 2 wing sutures on 2 sides using a 10-0 nylon suture, and you can see 2 wing sutures on 2 sides, and then a box suture to close the remaining area of conjunctiva. And to prevent the retraction, we can use a central mattress suture. This definitely reduces the chances of leakage. Plus, in future, if there is a leakage and you put a BCL, it definitely helps you to heal. In case there is a retraction of conjunctiva and there is a leakage, you have to take the patient back to the OT for resuturing. This is a suturing technique which we are following. And just last point, all patients who are phakic or angle closure glaucoma patient, I always use a subconjunctival atropine or maybe a drop of atropine before I close the eye. I think definitely it reduces the chances of malignant glaucoma. Thank you so much.
Thank you, Dr. Manish, for these wonderful videos. I would like to ask the audience if they have any questions for this session or the previous sessions to please drop in the Q&A section. And I would also request Dr. Praveen Arora, who is a senior and an experienced surgeon in Sirsa, to let us know what is the kind of practice that you have as regards glaucoma and which is your preferred surgical procedure. So when do you consider doing the trap? Dr. Praveen Arora, sir, please. If sir is not around, Dr. Rajan or Dr. Maheep, what is the local trend in Sirsa and the surrounding belt?
Am I audible, ma'am?
Yes.
Yeah, ma'am, initially the patients are being managed on the medical management first.
Right.
So whenever the multiple drugs, they do fail, then we consider the patient for the trabeculectomy because the post the complication the trabeculectomy has. Right. So Dr. Praveen Arora is doing routinely trabeculectomy. I am referring for the trap the patient to the glaucoma surgeon, but Dr. Praveen is doing the regular trabeculectomy, phaco with the trab as well.
Excuse me, I was somehow away.
Yes, sir.
Yeah, I'm doing trap only in those cases where I find that it may not be good to wait. But sometimes I have seen that some patients, they are allergic to all the anti-glaucoma medications. So that is my first indication. And secondly, there are very, despite medical treatment, they are not being controlled. So I do the trap. And my procedure remains that I make usually triangular flap and apply mitomycin under the conjunctiva. But in some severe glaucoma cases, like this neovascular glaucoma, I use mitomycin under the partial scleral flap. Well, that gives a real good benefit. Or only applying mitomycin under the conjunctiva sometimes it's not that potent as we apply mitomycin C under the scleral partial flap.
So, do you usually do SICS trabeculectomy or phacotrabeculectomy in your practice?
Yes, I do phacotrabeculectomy quite often, and it's from the same port. That first I make the the flap, partial scleral flap, and then I enter through my 2.2 or 2.8 knife, and after implanting the IOL, and then because the pupil is usually dilated in phaco surgery, so I put pilocarpine to constrict the pupil so that the PI is not very big. Because in a dilated pupil, it's very difficult to make a small PI. So after constricting the pupil, I do the PI and then make the trabecular trabeculectomy part, and then I apply the sutures, and it was really good combined procedure.
So having said that, there's nothing right or wrong in any of the treatment modalities that we offer to our glaucoma patients. So there's no set format. It's very flexible, and we have to customize it for each patient. And there's no substitute for experience. So there are lots of things that you have seen in your practice, and you manage your patients very well with them. So having said that, I would ask Dr. Manish and Dr. Shibal to add any pointers as regards their presentation, which were missed out because of the limited time. So anything else that you would wish to add for the management of glaucoma? Dr. Talveer, would you do lasers for laser PI for all your angle closure patients, or would you leave out a few and observe them for a bit?
Ma'am, in people who have angle closure, who are angle closure suspects, or not all the patients should be taken up for YAG-PI. In people who are developing, already started developing goniosynekia, and who have glaucomatous cupping in addition to the goniosynekia that are developing, all of those people should undergo YAG-PI. Otherwise, in angle closure suspects, we should see whether they have some risk factors associated. For example, if the pupils need to be dilated again and again, or there is a one-eyed patient, or the other eye has actually developed glaucoma, then we should go for, or there is a very high risk family, very positive family history, so then we should go for a YAG-PI early on. Otherwise, they should be followed up yearly.
Right. Thank you. Dr. Manish?
Ma'am, can I have one question, please?
Yes.
What is your experience with the new anti-glaucoma drug, the tarsudil?
Manish, would you like to answer? Dr. Shibal, I think, has good. Both of you can answer this.
Dr. Shibal.
So I don't believe in it. I'm really sorry, but I have come to the conclusion that a sixth glaucoma drug does really nothing to medical management apart from giving you a red eye. Incidence of red eye with nitarsodil. Nitalo is the brand that I have had access to. I have also used the innovator Proclatan. So because before it was available in India, I had I think 8 patients who were importing the drug at 38,000 rupees a month. So they were really trying. One of whom is Dr. Vanita Pathakre's aunt. I was surprised that she would be on 6 glaucoma drugs. Remember, giving a 60% incidence of dry eye, 20% incidence of subconjunctival hemorrhage. The incremental IOP decrease that you will find in adding one drug to your patient, it decreases every time, right? The first drug has 30% efficacy. The second will have 15% efficacy on the eye pressure that the 30% has brought it down to, not to your baseline eye pressure. 40 से अगर शुरू किया तो 30 पे आए, 30 पे अगर 10 से 15% और कम हो गया तो 3 मिलीमीटर और कम हो गया. अगली ड्रग और ऐड करी तो 10% भी अगर हो गया तो आप 28 पे थे तो 2% और कम हो गया, तो आप 26 पे आए. आप अगर उस पे नटालो ऐड करोगे तो 1 मिलीमीटर और ड्रॉप हो जाएगा बहुत से बहुत, जो कि टेस्ट रीटेस्ट वेरिएबिलिटी है आपकी. उतना तो वेरिएशन सुबह से शाम में आपको दिख जाता है. So you are actually adding to the burden of the ocular surface disease. You are adding to the burden of the patient in terms of how many drops the patient has to use, just because you want to defer surgery. Dr. Praveen बैठे हैं ना, किस लिए इतने दिनों से practice कर रहे हैं? सर के पास patient भेजो. Like I keep saying, glaucoma is more about teamwork than anything else. The number of times I have convinced patients to go to Chandigarh or Delhi is not funny, because नहीं है मेरे पास सब कुछ. हर कोई मनीष थोड़ी है कि 2 बड़ा आई सेंटर्स शादी कर लेगा तो जो चाहिए वो मिल जाएगा उसको. So don't be scared of referring patients, and always remember, अगर आपको 6 दवाएं डालनी पड़ती आंख में और सबके बीच में 5 मिनट का गैप डालना पड़ता, तो आप कितनी दवाएं डालते? I think that answers your question. There is somebody, I don't know who told me this in another of these programs that I was doing, that it is being positioned as the new first-line drug. I was shocked by even the presumption that we can think of it as a first-line drug. It is not. And as in conjunction with Xalatan, also, I don't think, I mean, you are adding it to a Xalatan bottle, but Xalatan is anyway less effective than the newer prostaglandin analogs. तो जितना वो ऐड कर रहा है उसमें घुस करके उस बॉटल में, उतना तो एक स्ट्रॉन्गर prostaglandin analog आप दे दोगे तो वो ऑटोमेटिकली नीचे कर लेगा प्रेशर. So
I want to say about netarsodil that as it is good for endo and corneal endothelium also, so wherever we encounter both the things, that IOP is raised as well as the corneal endothelium is also having problem, especially in PBK. So there, I think netarsodil may be.
You may prefer it to Dorzox. You may
Yes.
prefer it to Dorzox, but beyond that, not really. There's also some reports that people, अभी हमारे drug company वालों को ये याद नहीं आया इसलिए उन्होंने हमें ये पढ़ाना नहीं शुरू किया है. But they also kind of have a long-term effect on outflow facility. Trabecular meshwork के ऊपर भी काम करती है ये दवाएं. जो लॉन्ग टर्म इफेक्ट्स हैं वो जो अब स्टडी हो रहे हैं टिश्यू लेवल्स पे, लेकिन अभी ड्रग कंपनी वालों को पता नहीं चला इसलिए उन्होंने हमारे दिमाग में ये बात डाली नहीं है. So we're not discussing that right now, but sir is right. In case of compromised corneas, you may use it as a substitute for dorzolamide as a first choice. When you are considering dorzolamide, not as first choice to prostaglandin inhibitors.
Okay.
Right? अगर प्रोस्टाग्लैंडिन इनहिबिटर में नौबत यहाँ तक आ गई है कि अब आपको डॉर्जॉक्स ऐड करनी पड़े, तो डॉर्जॉक्स की जगह आप नटारसोडिल ऐड करेंगे. लेकिन याद रखेंगे पेशेंट की 60% केस में आंखें लाल हो जाएंगी, एंड 1 in 5 पेशेंट्स will keep coming back to you with hemorrhages and recurrent hemorrhages. और मेरी एक पेशेंट है श्रद्धा, बॉम्बे से आती है मेरे पास. वो 3 महीने पहले उसको फर्स्ट हैमरेज हुआ, उसके 1 महीने बाद उसको फिर हैमरेज हुआ, और अभी वो फिर शी फ्लू डाउन टू सी मी के मैडम तीसरी बार हैमरेज हुआ है. मैंने कहा जाके डॉक्टर शाह को बोलो कि बंद कर दे नटारसोडिल, देख लेंगे. So remember, what are we doing when we are adding drugs to the patient? Invariably, best to sir बैठे हैं, याद रखो सर बैठे हैं, सर ऑपरेट करके वापस भेज देंगे तुम्हारे पास पेशेंट. तो हमारा चूल्हा भी जलता रहता है, ऐसा नहीं है कि रख लेते हैं रेफर करने पे पेशेंट्स.
Dr. Manish, your experience with the drug?
First of all, I'll agree to Dr. Shibal that no one wants the 6th drop. But when you're having a glaucoma practice, as Dr. Shibal is having, we get varieties of patients. Like suppose I have a patient who we can't use prostaglandin, like a secondary glaucoma, say uveitic glaucoma. I can't use a prostaglandin. There you are using, say, brimonidine with timolol combination. You want to add a medicine. These cases, ROCK inhibitors are good. So there are different types of cases. Again, patients where you can't use beta blockers. Say patient is already having asthma. So you are using, say, brinzolamide, brimonidine combination. You want to add something, you can add. So not as a 6th medicine, but as a 4th medicine or a 3rd line drug, it has a role. My experience is there with Netalo also, and now Reiki is available, and Ripatech was also there. Ripasudil is actually, which has been used by the cornea doctors for the endothelial function, to enhance the endothelial function, not actually netarsudil, because netarsudil, a lot of reports are coming with epithelial edema and toxicity. But cornea doctors are using more of ripasudil. Again, we'll see over time how useful they are, but that has been promoted. Initially, when Netalo came, I used it a lot, and terrible redness. But again, no financial interest. I feel Reiki has a lesser redness. Could be because initially when we were given samples of Netalo, we were given in cardboard boxes and said, where is the cold chain? You're not maintaining the cold chain. So these all issues will be there in our country, because netarsodil has to be properly maintained in a cold chain, and ripasudil you can keep on room temperature. So a lot of factors are there. But I feel as a glaucoma doctor, I don't mind having one extra weapon. May not for all patients, but once in a while I would like to use them. And again, the responder rate, we know that every patient has a different responder rate. There are patients where patient is on prostaglandin, you add a timolol, you get a 5-6 millimeter extra IP reduction. And another patient, you add timolol, you just get 1 millimeter IP reduction. So with netarsodil, I've seen some patients have got 5-6 millimeter IP reduction. Some patients have got no IP reduction. So nothing bad in trying. And redness definitely is an issue. But again, it's variable. There are a lot of patients who don't have redness also. So I say it's 50-50. It's worth giving a try in a specific group of patients, not all patients.
So yeah, maybe in another year, we would be able to better answer this question. It's too early, and in COVID times, we did not really have follow-up of a lot of our patients. So let's give it another year to be able to answer this question better. So we have anyway overshot by half an hour, and I would request the local or committee to convey a vote of thanks. And from my side, I would like to thank all the esteemed speakers for shelling out 2.5 hours on a Sunday evening, and also to AICE for actually supporting us in this endeavor. So I would request the host society to please step in.
Yeah, on the behalf of Sirsa Fatehabad Ophthalmic Society, I would like to thank Dr. Parul Ichpunjani and all the esteemed speakers who have spared the valuable time for our society, also several areas of Haryana, and you have given us the valuable time. So we expect in the future, just give us more time so we can discuss more new things, because glaucoma is a disease which has so many, it's always confusing for all of us, whether patient having glaucoma or not. So we can have the more talks next time, and thanks a lot for giving us the time. Thank you, ma'am.
Thank you so much. Thank you, everybody.
Especially thanks to the pharmaceutical company, ACE Pharmaceutical Company, for supporting us, Mr. Jatin and all their colleagues.
Well, thank you, everybody. Rohit, would you like to step in?
Yeah, thank you so much, ma'am. So wherever you think we are relevant, we are always there to partner with the societies. Thank you so much.
Thank you, everybody. Have a wonderful rest of the evening.
Thank you.